Good afternoon, everybody. Welcome to the Health and Adult Social Care Scrutiny Panel. Before we start these proceedings, excuse me, I really have got this horrible virus that's going around, so please excuse me. I'll bring to your attention some housekeeping matters. There is no expected fire alarm testing today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. This meeting will be broadcast live to the internet and will be capable of subsequent repeat and viewing. By entering the Warspite room, committee members are consenting to be filmed throughout the meeting and to the use of those recordings for webcasting. Can I please ask that you speak clearly and directly into your microphone when addressing the meeting so that other online participants and public can hear, and that it is switched off when you're not using it and your mobile phones are on silent. Thank you. Right, item 1, apologies. Elliot.
Thank you, Chair. With apologies received from Councillor Riley and Councillor Nicholson, not aware of any substitutes. Thank you.
Thank you. Item 2, declarations of interest. Anybody got any declarations of interest? Will?
I work at Derbyshire Hospital.
Ray?
I sometimes work at Derbyshire Hospital as well.
I work at Derbyshire Hospital.
I don't work at Derbyshire. Item 3, minutes of last meetings. Everybody approved the minutes of last meeting? Yeah. Any amendments? No. Can I have a proposal and a seconder, please?
Yeah, those.
Yeah. Everybody in agreement? Yeah, there you go. Thank you. Chair, there is no chair's urgent business. Item 5, quarterly performance and finance report. And that's, we got Helen, Stephen. Oh, Helen and Stephen. Thank you.
Hiya. So we've got a summary version of the month 6 report for you, because it wasn't that long ago since you had an update at month 5. It gives you the details of variances per the different care package types. Just a couple of things to note as a saving on residential long stays of 651 and nursing pressure of 647,000. So they offset each other. Most of the others are close to budget, but we're seeing a pressure on short stays and respite, which we're investigating, and also a pressure on domiciliary care now. So overall, that takes the variance to an adverse variance on the care packages of 471k. Last month we also mentioned that we have reducing client income come in. That is part of our reported pressure, but that pressure is being mitigated with other savings at month 6. And just a couple of other things I wanted to mention to you is about things that are impacting our budget setting for next financial year. So we've had the national living wage now agreed from April 2025 at £12.21 per hour. So that has a direct impact on our rates that we would be setting for care providers. On our initial modelling, we had put in £12.10 per hour, so there was an increase. So that will have to be factored into all the budget setting that's happening at the moment in PCC. But that was something anticipated because that happens each year, and we almost got it at the right level. But what we didn't anticipate were the changes to national insurance rates and thresholds at quite the significant level that they have been. And we're currently modelling the impact of that and how that will be passed on to care providers. And the message from MHCLG is that there will not be a separate funding stream to cover that. It will have to come from existing announced pots of funding. So we get the local government finance settlement at some point next week, so we should have more information there on our levels of funding and if there definitely isn't any funding for that, or how we will be able to fund that. But again, that's part of our ongoing discussions at the moment about budget setting. Does anyone have any questions?
Anybody got any questions? No.
Just to say that it's been hard work getting to this stage, and I really want to say a big thank you to everybody for getting this. And it's quite, if I say usual in inverted commas, to be at this level now, but I am reassured that come the end of March we will have a balanced budget. So big thank you to everybody that's really, and it's tough. I mean, at the moment it really is tough. So big thank you to everybody.
Thanks, Mary. I mean, it is looking good, so well done to everybody.
Shall I go on to the performance report? Good afternoon. I'm sharing mine on the Teams channel, so it's on the screen. For today's, it's going to be a slightly briefer performance update, this part, because we have colleagues from Livewell here who have a separate item where we're going to focus in on the waiting lists. So I'm actually going to skip the first couple of slides that show you the data on waiting lists, because they will be covered in the report that Ian's presenting for Livewell later, and we can obviously we can be included in that discussion as required. So I was going to move on to the slide on residential and nursing care, and just cover the ones which are solely the responsibility of Plymouth City Council. So the performance shows that we've actually seen a reduction in the numbers of people that receive nursing care, and a small increase in the numbers of people who receive residential care, so they've actually crossed over, which is slightly contrary to the, as we've just heard from Helen actually, to the actual spend. But we are within the budget, or we're within the budget for residential care, but slightly above budget for nursing care. So what that suggests is that the complexity of people receiving nursing care is higher because the average cost is higher, which isn't unusual. But we're just looking at the increased number of people that are going into residential care. We're not seeing a trend in terms of less people going home from hospital, because we're still seeing good numbers, high numbers of people returning home from hospital rather than going into a care home. But we're just wanting to understand what's causing that increase in the numbers of people receiving residential care, in terms of that having gone up. Working closely with NHS partners to analyse that data and those numbers. So I'm happy to take questions on that. I can move on to, shall I carry on, and then if you've got questions you can just put your hand up. Domiciliary care.
Hang on, Steve. Kathy wants to ask a question.
Sorry.
Hello. Thank you for that presentation. But as a layman and sort of without medical speak, can you please explain what DTA of ELOS is, please?
Yes, and I apologise for that, because we did, Mary did pick that up, that we've left in some abbreviations into this report, so we fed that back to the person that's put it in. It's discharge to assess, so it's when people are discharged from hospital and into a service, and then we undertake an assessment. So it might be in a nursing home, in a rehabilitation centre, or in their own home for a short period of time, where we then undertake an assessment for what their future needs might be. And apologies again for any abbreviations, so we'll make sure we correct that for the next time. But yes, please ask me if there's any more. Extended length of stay is ELOS. And LT residential is long term. Okay, so moving on to domiciliary care, the number of people receiving their care at home has increased slightly, which is positive that we're supporting more people at home, although we're obviously seeing that slight number increase in residential care. And 7.4% of those are receiving that in intermediate placement, which is a short-term period of care, and then they're independently living at home. We're engaging with providers in December to support plans for the future commissioning model of our domiciliary care, maximising choice and using local provision. And then direct payments, and I think you need to look at direct payments alongside domiciliary care.
Angela?
Yes, it was just that paragraph, the last second paragraph in domiciliary care. I just wondered what the future model might be like. How is it likely to change in, I'm not familiar with what you would mean by what's specific about local provision, and so how would this model change?
We brought something to Scrutiny last time about how we were looking as to what we're providing at the moment, and is that still the applicable thing? And so therefore we've been going out to care homes, which I think we may well find that some of my colleagues behind me will say more about, but it's been consulting with people. Is what's being provided the right thing, and sort of how their satisfaction levels are on that. And we've had Health Watch going in to care establishments to see, because obviously there's always fine tuning that we can do, and we want to improve people's experience of being in
And
these
as we
facilities.
have so many, such a large
Yes,
number.
exactly. And, we just want to make sure we're getting it right, because we're commissioning these services, and it's making sure that they are the right services that we're commissioning, Angela. That's really the most important thing.
Thanks a lot. Thanks,
Thank
Mary.
you. And then, yes, moving on to direct payments. So that direct payment is when someone manages their own support themselves, and we pay them directly to recruit or employ their own personal assistants, or they can use a care provider. And we've seen a slight reduction in the total numbers, but actually those people no longer needed a direct payment. So it's to do with we're actually increasing the number of reviews we're undertaking and making sure that people are receiving the right level of care and the right type of care. But we are also working hard to make sure that staff are trained in the use of direct payments, and we make direct payments easy to access for people, because actually we'd like to see more people having independence over their care, and slightly less numbers of people receiving through a domiciliary care arrangement. And then reablement. So this is short-term reablement for people. Our reablement service supports people leaving hospital for up to 6 weeks. We saw a slight reduction in the demand for reablement in the last month, in this period in October. And work was underway, or is underway, to expand the reablement service to not just support people following an admission to hospital, but also to support people from the community or to avoid hospital admission. But we're seeing positive outcomes for people receiving a reablement service, and our percentage, which is a national reported data, which is the percentage of people still at home 91 days after a discharge from hospital, is still good, around the 80% mark. And that's all of the adult social care. I'll just quickly go to the last slide on this pack, which is the no criteria to reside. So, sorry, NCTR is basically the way that it's reported someone who is in hospital that's fit to be discharged, that's well enough to be discharged. And this shows the figures for Plymouth, Cornwall and Devon, Plymouth being the blue. And we are on target at 9%, we're just over 9%, but our target is 9.36%. So despite some of the pressures that we've seen in Derriford Hospital in the last couple of weeks, actually we have managed to control and respond and continue to be able to discharge patients at the same level.
Mary?
Thanks, Chair. This is where I get very cross when I read some of our newspaper headings, which claims that Plymouth is holding up Derriford's discharges and whatever, because you can see for yourself the evidence is there to say Plymouth social care is holding its own, and there is that one little, well, a couple of little blips, but that probably is only one person, if you see what I mean. So I think that's what gets me very irritated, and Jemima has to keep me under control sometimes because I sent something in. But I think that, hopefully that you can see that the team is making sure that we don't block beds in Derriford as best as we can.
Okay.
Thank you, Chair. I don't know which section this fits into, but I think it's a question about carer burnout more than anything. And I'll do so anecdotally with a case that of a woman who cares for her daughter, who is a young adult in her late 20s, has quite not an insignificant package of care, but that enables her to go to work, and that's when she uses the care. And she commences her own caring duties as soon as she leaves work and picks up her daughter. She does this with no breaks whatsoever. She cares for her every hour outside of the hours of Monday to Friday, 9 to 5. She is struggling, and she's been caring for nearly 30 years. So she requested a bit of extra support after some heavy encouragement from her friends. And she was very positive about the staff that she spoke to, incredibly positive actually. You couldn't have had a better experience in terms of talking to the staff who were reviewing the case, but ultimately she felt that she felt a burden for asking for additional support, because there was immediate talk of, oh, this would have to go to panel, you'll have to wait. Perhaps some of the language could have been better, but ultimately, when she asked for support at a point where she was at her limit, she hasn't yet got it, and it's been quite some time since she made that request. So we know that the cost of carer burnout would be significantly higher than a few additional hours in that care package. But I just wanted to ask if how that sits with you. Is that what you would expect? How long would you be waiting people for? How long would you expect people to be waiting for a review of packages? And in particular, how you feel that might impact on carers as opposed to the person being cared for?
Well, I think the question about how long she was waiting to have a review or an assessment, probably we should come to that in the next section, because we're going to be drilling down a bit more into waiting times. But in terms of her being an informal, unpaid carer and the amount of care that she's providing, she's also entitled for support as a carer. So we do support carers to have carers assessments to look at what support they need in order to continue to manage. And it may be that the outcome of that is that they then need extra support for somebody else to provide some of the care. So then the person they care for would need a Care Act assessment in their own right. So I guess we commission a service through Improving Lives Plymouth to support unpaid carers, and we have we get a good service from them. I think there is a lot of support available for carers. But I think the question about the support and how long she's waiting to have that care to support the person she cares for is probably to discuss in the next section.
Anybody else got any questions, sir? Lauren?
Can I just mention the sickness data, because I think it will come up in the actions. There is data, I think it's not in my pack, Elliot, but I think it's in the pack that's been circulated. And there are a number of actions. The sickness data was specifically around the care workers having a higher number of sickness absence above the target for Plymouth City Council. And there's a number of actions in place that, in order to support managers to manage sickness as effectively as possible. So the main reasons relate to kind of cold, flu, COVID type symptoms, which is obviously meaning for a carer they can't go into work when they have those types of illnesses, whereas office workers would still be able to work or work from home. But I just wanted to reassure, because sickness, that's not normally included on the report. It hasn't been in the past, but I think it was included in the report a couple of times ago. So there is a lot of work being done to support the staff, but also to support the managers to make sure that those staff are supported to be able to get back to work and reduce sickness in the services.
Lauren.
Thank you, Chair. I want to pick up briefly on the intermediate placements, and I think it's really great that those have been separated out in the report. I was wondering if you could go through what support those people in intermediate placements are getting and those caring for them, just as we know that it's that kind of like in-between period. Are they getting the support that they need before they then move on to their kind of ideal placement?
So if it's intermediate, was that on the domiciliary care page? Yeah, so if it's domiciliary care, then basically they'll have a period of up to 6 weeks of reablement, which is following a hospital admission to support them at home, to manage their personal care or perhaps practical tasks such as making their breakfast or making a cup of tea, to be as independent as they can. And they're very skilled staff who will work with people alongside them and their carers if they have carers living with them to try and maximise their independence. And then sometimes they just need that for 5 or 6 days. Sometimes that goes on for 6 weeks, and that's provided for free. And then that will then, if they need ongoing care, during that time they'll have an assessment from a social worker or community care worker, and then we'll arrange a longer term service for them. So they're mostly older people leaving hospital following a period of time in hospital.
Kate.
Thank you for the sickness figures. Really helpful graph of the rolling year bar chart. Sad to see any level of stress related to work, time off work, but actually, given the level of complexity that workers in adult social care and community connections are seeing, I'm actually surprised it's not higher. So that's actually probably almost wholly down to managerial support, so that's really good. There is no stress bar chart in the long-term absences for strategic cooperative commissioners, so can we assume that there is no long-term sickness in relation to stress within that team at all?
Yes, I think you can. Yeah, I'll go back and check. But yes, that's basically our commissioning team. So there's been no one in that period that's where that's been a reason for their sickness. It's a relatively small number of staff. But yeah, because in the other charts, there's three different colours, and there's just 2 for that. So yeah, but I will go back and double check because I'm sure they experience stress, but they're managing to continue to work.
Yeah, assuming that's the case, that's very good news. That's very good news. Well done, Gary.
Has anybody else got any more questions? No. Okay, we just recommend that we just note this report then. Is that okay? Thank you. Thank you both. See you next time.
Okay, I'll stay for the next presentation.
Do we need to shuffle around?
Item 6 is Live Well Performance Report, and we've got Ian Lightly to present this one to us. Thank you.
Just bear with me, I'm getting the slides up, hopefully. Oh, no. Wrong one. I have, I'll come to that in a second. Right. Good afternoon, everybody. Thank you for inviting me. I think I've been here 2 or 3 times now. My name's Ian Lightly. I'm the Chief Operating Officer for Live Well South West. I was going to be joined by Sarah Pearce, who's one of my assistant directors, but She's been called away to some other urgent matters. It's quite a busy time of year at the moment, so you've just got me. I'm going to go through the sections that I've listed up there in a second, but I just wondered whether to keep the flow going, whether we wanted to pick up on some of the points that we've deferred to this section first, and then we'll kind of get to them anyway. So I wondered if we wanted to just touch on the example you gave about the person and the delay between getting their support package. So Mary, I think you touched on this earlier in terms of the financial position and the way that we're having to apply really tight controls and consistency. So the panel process that you mentioned in your example is something that we've had a version of in place, I think, and most local authorities have something equivalent for a number of years. But we've really stepped that up over the last sort of 12 to 18 months to try and make sure that we're applying decisions really consistently and live well, because ultimately we're making decisions about spend on behalf of the local authority. So when I come onto a slide later on, there is some data suggesting it is taking us longer now to complete some of our assessments, and I think that is one of the reasons. So it's trying to get that balance right between having really good, consistent, financial-based decision-making whilst also keeping the person in the centre of it, and I think your example suggests we haven't got that right. And it's also a lot about how we communicate that, and I was really struck by your words about the person feeling like a burden. And I'll take that back as well, because although we do need to do those things, there's something about how we reflect and use empathy to recognise what that might feel like in that person's position. But there will be a slide later on that shows you what's sort of happening typically to the length of time it's taking us to complete assessments. Okay. And then I think waiting times in general, I won't go into forensic detail, but I will have a section on that as we get to it. So first of all, I was asked to bring a summary of the services that Live Well delivers on behalf of Plymouth City Council. So I thought I think it's the first time we've been invited to do that. So I've given you a broad sweep, but I'll try and go through as quickly as I can, because I know we're limited for time. There we go, first hurdle. Can I get the slide to move on? There we go, lovely. So first of all, I'm colourblind, by the way, so whoever put this together for me had a good sense of humour. So on the left-hand side, you can see that's the workforce that we had in 2015 when we first came across from the local authority, and I was actually one of the managers who's worked in the local authority in social care, and then I've been in Live Well now for nearly 10 years, so I've kind of got a bit of experience of working in both settings. That green bar represents the total number of staff, and what you can see is between 2015 and 2019, quite a sharp increase in the overall number of social care staff that we employ. Now, that's not because of additional investment from local authority, that's as a consequence of other commissioning investment, largely from the Integrated Care Board, the ICB, particularly to enable us to be much more effective around discharging people from hospital and also avoiding people going into hospital. So although we've utilised that money to increase our social care workforce, it's kind of come from other sources, so I thought that was probably worth pointing out. And the other thing of note, if you look at the little, I think it's blue, the blue bar on the left, that's our occupational therapy resource. We had about 20 people in 2015. That's grown to nearly 27, 28 now as well. And a lot of that is, I think it was your question around what support do we provide to people in intermediate care placements. That the OTs are one of the key professionals that provide that. So we have a little bit extra there as well, but still not enough. And I'll come on to that. So I thought that was helpful just to give you a sense of the scale. Now, if Stephen had to apologise for acronyms in his presentation, I'm positively in the doghouse. So we've got an awful lot of acronyms here. So I do apologise. I'll run through them all so you know what they mean, and I'll remind my colleagues of how important it is to spell these things out. But this is just a run through of how we organise adult social care services and the areas that we focus on. So on the left, we're fairly obvious that one. That's safeguarding. So we have a safeguarding team, which at the moment we're working really closely with Stephen and his teams on to bring those two together. We have a brokerage service, which again is a collaborative effort. So that team tries to source packages of care really, really quickly in a timely way so people don't have to wait for a long time. Learning disability, ASC is adult social care. Learning disability is LD, and we have a team that works very closely with our health learning disability colleagues. LRSS stands for Live Well's Referral and Support Services. I'll speak a little bit about that in the next slide. Then we've got our mental health and well-being. So there's a reasonably small number of social workers who focus primarily on mental health, but there are other social workers in Live Well that work in some of our mental health teams. DTA came up previously, so that's our discharge to assess team, and CCRT is Community Crisis Response Team. So that's the team who tried to prevent people from going into hospital. And then finally, we've got our care home service, which is CHS, which is a team we created in COVID actually to try and support care homes with a bit of a lifeline, but also to control footfall at the time. But it was a very popular service, and as a consequence, we've built it into our model now, and we've just revamped it recently. And then finally, we've got our locality teams, which is really our sort of everything else. So we have 4 localities, north, south, east, and west in Plymouth. And then around the edge, we've got our administrators and our principal social worker at the top, who is now a joint appointment. So that's the principal social worker who works across Live Well and the local authority, and her role is to ensure with her practice educators that the standard and quality of practice is good across the teams. Okay.
Sorry, before we go any
Yes.
further, can I just ask, we're talking about the workforce, and you can see that really the workforce hasn't really increased, has it? If you look at over the years, it's not really increased. Like 2021, it's not really increased that much. But I'm assuming that people that are needing the services would have increased. Am I right in saying that? So the workforce hasn't increased, but the people that are needing those services, like for example, mental health issues, I'm assuming that would have gone up, but we've not got the staff to accommodate. Am I right in saying that?
So yeah, you're quite right. So apart from that sprint between 2015 and 2019, where we did increase our workforce, it hasn't moved since then. And obviously we've had COVID in the middle. To your other point, when I go through some of the other slides, yes, I think you're right. There is more need. There are different types of need coming forward now than there would have been in 2015. And generally, because our population is ageing, there are more social care issues which can be associated with age. Not a given, as somebody who's about to watch his dad have an 80th birthday on Saturday and he's running around having a whale of a time, but there is obviously more need as people get older. So yes, if you look at that growth, there isn't the same amount of growth in terms of the workforce, which means inevitably teams have to prioritise what they do and what they can't do. And it means for Live Well, as an integrated provider of health and social care, we put a lot of our effort into finding ways of becoming more efficient and effective by using all of our workforce. So, for example, we've just concluded a piece of work that's taken 2 years called Shared Skills, which means that our community nurses, therapists, physios and healthcare colleagues are now aware and becoming competent in being able to offer advice and information about elements of social care and the Care Act. And the more we can do that, the more we can sort of cut down on the number of referrals we get, because we're able to deal with things at source. So those are the sorts of things we're trying to do to keep up, if you like, with that growth without that additional resource. We're trying to support colleagues to make every contact count, so to speak. So, okay. So just very quick, this is a very simple drawing, as you can tell. This doesn't describe the whole of Live Well's model or anything close to it. But just in terms of how the majority of work comes into us for adult social care, it still goes through 668,000. So if somebody wanted to ask for a social care assessment, that's still their point of entry, unless they were in hospital, in which case we've got a different route for supporting people there. And then calls will be put through either as a live call, if it's urgent, or as an electronic referral to our Live Well Referral and Support Service. The main aim of that service is to try and offer advice, information, support and signposting where possible. There is a huge range of need that comes through for social care. The level for eligibility for an assessment is sort of really low deliberately, which means we have to do an awful lot of work to try and identify who needs to be pulled further in for an assessment and who can be signposted out. So that's what that team does. It works next door to a team that triage district nursing referrals. It works next door to our mental health first response service, and they're all co-located deliberately because they can collaborate and work together to try and provide that sort of integrated response I was talking about before. There is then a sort of decision-making point where we identify whether the needs are predominantly likely to be met by an OT or a physio, and our OTs and physios are all integrated within LiveWell. When I came across to the organisation in 2015, I was very, very surprised at how many individual patients from the health side, service users or citizens, were open to both a health and a social care OT, and that was not uncommon for people to be referred into both services. And when we were working separately, we wouldn't know that, or we might bump into each other as we were going up the garden path. So the reason we've integrated those is to make sure there is just one therapy offer. And then after that, the work will go down into either a social care team or a therapy team. Once it's there, they work very closely with their nursing colleagues and therapists, and any other conversations after that take place there. Now, on the right, I've referred to a priority system, which is a simple red, amber, green rating. And we said earlier that we absolutely have to prioritise the work that we get in. We are going to be moving away from that to a simpler system of either urgent or routine. But at the moment, we have still been using that as a way of identifying what level of urgency somebody needs. And I think there have been some examples where letters have been sent to people saying you're amber on the waiting list, and that's not meant an awful lot to those people. So we've had some work to do around that as well. We'll touch on that in a sec. So waiting times, some good news. The work that we've done since April, and this is also coincides with the increased closer cooperation, I think, and collaboration between ourselves and Stephen's teams and the local authority, is a pretty significant reduction in the number of unallocated assessments. So in layman's terms, that's a waiting list. That means that's a piece of work that hasn't yet been allocated to somebody. So you can see a fairly healthy number has come down. Now, that isn't all true, if you like. That's not all true demand. That's a lot of old data that needed sorting out and historical information that would have come across when the old system migrated. But nonetheless, you can see that's kind of come down relatively significantly. And then on the bottom slide, you can see the same impact on overdue reviews. Now, those are still some very high numbers. And historically, those have always been very high. And there isn't a statutory time frame for a review, but generally, beyond a year, you'd be looking at being overdue. Some people need them much more frequently than that, but that's sort of our ballpark. So that's quite a significant amount of work. And I think Stephen mentioned the shift in direct payments that we've seen has also corresponded with that targeting of increasing review work. So when you start to do work like that at an accelerated pace, it has some knock-on effect somewhere along the line because you're going back to situations which might not have been reviewed for some time. It's more common for people to re-present actually during that period, and then we would do either a review or a reassessment. So that's positive, but in the context it's positive, but there are still some large numbers there. So the next slide, just to, again, these are the not so positive numbers. So for Care Act assessments, the top number there that's a case that is allocated. So that's not on a waiting list. That's open to a social worker or a community care worker and has been open for 507 days without being completed. And I'll talk a little bit about why I think that is in a minute. And then we've got our longest case, which is 503 days. That is on a waiting list. We have a real issue, coming back to the red, amber, green prioritisation, that with so much need and varying priority coming in, somebody who may have a lower level need can get perpetually queue jumped if something that comes in today is more urgent than the person's need that's waiting on there, which is why we're doing that work around looking at changing that to a urgent and priority. And also people's circumstances change during that period of time, or they may present through a crisis, or they may present through the hospital. So the way we manage that risk is by giving everybody clear information about how to get back in contact us as soon as their circumstances change, which allows us to re-evaluate it. And we have really robust crisis responses. Now, that's not where we want to be. Of course, we don't want to be much more proactive than that, but with what we've got to play with in terms of our overall workforce, that's where we are at the moment. This doesn't end, by the way. This isn't where it will end. We'll be carrying on drilling into those numbers and reducing them down. And then it's a similar picture for England.
Sorry, that those figures are not acceptable. You're talking 18 months for people to be waiting to be assessed. Do you think that's acceptable?
No, I don't. And that's not the typical wait.
Sorry, Ian, but you've just said that you've got people that are, might come in and their needs might be greater than that person that's been on that list for, I don't know, 18 months. But that person that's been on that list for 18 months, their health could be, or whatever, could be deteriorating. So I don't understand why we've got these sort of figures after 18 months. That isn't acceptable. I'm aware that we give X amount of money to you for these services. Is it, so I'm assuming the money that we give you as a local authority includes this? Is that correct?
Yeah, so for all of the Care Act assessments that we are required to complete, the money that comes in our contract and the workforce I've just shown you, that's the workforce that does this activity, yes.
Okay.
So the only thing to mention, that longest one, and it isn't acceptable, but that's not a high number of people. Typically, that is not how long people are waiting. That is the very longest wait. And I think if we want to do, if there was another session like this, I'd want to come back and we could bring a different slice of that data to show what's a more average wait. That is the longest one today on there. That's not how long most people are waiting by a long stretch. That's the very longest.
What is the average wait at the moment then, please?
So
off the top of your head.
So the time it takes, this is on the next slide now, and it is actually quite difficult to piece that together with the data that we have. So the data in here is from the local authority's Eclipse system, and the way it stops and starts clocks doesn't make it entirely easy to be able to tell that from the person's perspective. What I can tell you on this slide is once the work is allocated, so once it's in the hands of a social worker or a community care worker, it takes on average about 30 days to complete it for cases in the community, and about 28 days or so for cases that are in that intermediate care offer, so it's either hospital discharge or admission avoidance. And that has increased from last year by about 10 days. And that's where I think the additional rigour around the panel process, the scrutiny, the consistency has added in some of that delay. But I also think we're starting to see slightly different kinds of needs present, which are more complex and which therefore take a bit longer. So once we receive the work, we don't do too badly in terms of turning it round, although we are setting targets to try and improve that. But it's the point before then that obviously from the person's point of view is most important.
Well, the red, amber, green system, this rag rate. If somebody, one bit of casework, somebody was told they were, I don't know, high priority or whatever the phrase was, and then they've waited months and months and months. That's if somebody meets the criteria to be assessed,
They need to be assessed.
you're sort of pushing the people, and then they're on that kind of a waiting zone forever, and then they probably give up and sort their own. But surely there should be the criteria for getting into that system to start with. It shouldn't be people who are green and then just kept for hundreds of days. It needs to be clear, and it's not. That's unfair on people who are waiting as well.
Yeah, I think Stephen wants to come in as well, because this is an area we've been working on jointly.
Yeah, just to say, you're right. I think it's with the red, amber, green, and my view is that anybody that's green, we should be giving them information, advice and support at the point they contact us. Because it may be that they're waiting for something that they might not ultimately need. And actually, what Live Well do really well is when people are waiting, that they cross-reference other types of support that they might be getting. So they might be receiving visits from a district nurse or other health professionals, which therefore mean that the priority for them to have their social care assessment is sort of goes down a bit because we know they're okay. So it's not that they're waiting with us and not having any knowledge over what's happening, but what we want to do better is give a quicker response to people whose needs are less urgent so that we can focus on the people who are more urgent and have more complex needs, because the waiting lists are made up of quite a wide range of levels of need and support. And I think that means that the the data can be a bit difficult to interpret because it's such a wide range of different situations. So the urgent people do get seen much more quickly, but we'll try and get some data that shows the average waiting times against the priority, perhaps, so that's a bit clearer.
Gary just wanted to come in.
Thanks, Pauline. I just thought it was helpful to go back a bit in time to remind people of some context of what we were doing. And we came to hear, and I think the Health and Wellbeing Board actually, with the presentation of the CQC inspection, and we gave you some headline information around what we called our kind of self-assessed strengths and weaknesses in our system. One of the things that we talked to people about at that time was that we felt waiting times were unacceptable in this city for individuals, like many authorities, actually, most authorities across the country. And what we did was we wanted to make sure that we were being transparent and showing people those figures, as well as let you know we were embarking on a programme of work with Live Well and our partners to start to address that work. What I hope, and you can see from this, nobody wants people to wait for the amount of time that we've shown, but it's absolutely right that we show some of those experiences. And what Live Well have done today is come and shown us actually some of the worst of that, which is just to make sure that really that lands. But what I would like to do is make sure we're aware that is in the context of work in progress, that is in the context of those things coming down through the year. And what Ian will go on to talk about in a minute, which is where our conversations are starting to go, is that waiting well in how we do and where we recognise when people are waiting, we're doing the best job that we can for them in that situation. And that will draw on some of the things that Stephen has just talked about, and Ian has also mentioned around how you use other services to make sure you understand what's going on. Because that's also part of that improvement plan work, to make sure that for those people who are having to wait, that we're doing it and we're supporting them in the best way. So all I wanted to do was give some of that context. And this is actually a really positive step for me in terms of that process, that there is a chance for you to ask questions and do all of those things. And it might be something about what else happens next in terms of continuing to show you the trajectory and what's happening.
Okay, thank you. I don't know if I've misunderstood the waiting times character assessment side, but you said once they're allocated, they're done quite quickly, and the 30-day average once allocated sounds all right. But does that couple of slides back from this one not say that someone has been allocated and is still waiting 507 days?
Yes, and I'm going to come on to that in a second. So, well, I'll get to it now. Actually, I'll come back to waiting well, if that's all right. So one of the other things that I'd asked our analysts to look at is what we're seeing in terms of age range of referrals. So you would think that with an ageing population, so to speak, we'd see our over 65 work actually growing, but we're actually seeing the opposite. So there are more people now of working age that are being pulled into a Care Act assessment process than there are over 65s. And on the next slide, you can see that the number of care packages, so direct payments, care packages, etc., for that group is significantly declining. So what that suggests to me is we've got a cohort, a different kind of demand coming through for people who are probably receiving what would have been long-term social work interventions, which again hints at a different type of demand, potentially linked to self-neglect, complexity, mental health issues as well. Now, that's not proven by the data, But certainly from speaking to the teams myself and to the managers, that is what we're starting to see. Now, procedurally, it's not correct that that assessment doesn't get completed. There should be a decision made about that person's need much earlier than that. And then if the social work input is the right thing to offer, then that's really the support plan. So that 503 days is a bit misleading. That's probably somebody not really understanding how to close the process down. They shouldn't have to take that long to make a decision about a person's eligibility. But I do think we are seeing an increasing number of longer term pieces of work for people linked to hoarding or self-neglect, where best practice is that we try to maintain frequent face-to-face contact with some of those, particularly those high-risk individuals, contributing to some of those longer periods. Does that make sense? Ish.
Ish, yeah. I mean, it makes sense. So if hopefully that is a procedural error, and then that means that that number will come down significantly as soon as you rerun the report. So fingers crossed for that. I think this is really frustrating. It frustrates me to see this because I know that it's not the fault of the social workers and the workers that are doing these assessments. It absolutely isn't. It's the result of chronic underfunding of services like this. And I think it is a difficult balance with a RAG system because, as Pauline says, like people can deteriorate whilst they're waiting. We also know that early intervention will save us money further down the line. And as Stephen said, it clears the waiting list for workers to be able to focus on the people who need it. There is no answer to that. It's a perpetual question. Same question that I faced when I was cabinet member, same question that probably many of us before faced. But ultimately, the problem is staffing, whether that is the number of staff or the ability to retain staff or the ability to recruit staff. So we've seen from previous figures that the number of staff hasn't increased in Live Well by much, if at all. Is the answer more staff? Are you struggling to recruit people who are able to do this work? No. So it's the number of staff.
So we have very good retention. So we have very little people leave Live Well from a social care perspective. Sickness is across the organisation. The last couple of months has started to go up again, but there's been an awful lot of sickness going around, isn't there? Typically, that's been on a downward trend over the organisation. Retention isn't the issue. Recruitment isn't the issue. It is, apart from all the things that are within our gift, like thinking smarter, like some of the shared skills work I've talked about, like closer integration, there is clearly a gap between what we're able to manage and what's coming in through the front door. And as Gary said, that's not unique, I don't think, to Plymouth. We do have some unique tools that we can use, but they're not easy. I can't walk into a team of nurses and therapists and OT and say, I'd like you to all start doing care act assessments, please, tomorrow. It doesn't work like that. So some of that work takes time, and it takes a bit of quid pro quo. But ultimately, that is one of the key factors. I will never say that's the only thing, because there's always things we can do within our gift to try and think smarter and more effectively. Of course there are. But the size of the gap is such that even if we achieved all of those innovative things, there would still be people waiting longer than we would want. I think, as Stephen said, though, it is about providing advice, signposting and information to people, and perhaps for some people calling us back later on in their journey when they have got to that point, which is closer to the point where they need it. And in the meantime, we really push out that self-help, that self-support. We look at our wellbeing hubs. We work with our voluntary sector colleagues to try and create the infrastructure in neighbourhoods to allow that to really start to thrive. So I think those are the areas we've got to go in. But yes, at the moment there is a gap, and that is more stark for OT work than it is for social work even. Okay.
Lauren?
Thank you. I really appreciate these are challenging figures to present to us, and I really appreciate the candour and the honesty, and for the extra context as well. That's really useful. Bearing in mind the national context, you guys are being asked to do more with less. It's really challenging. I appreciate all of that. Could you go through what the average time for a Care Act assessment allocation is? Obviously, we know that when they get that allocation, it takes those 30 days, but what's the time period they're waiting before that? And also moving forward, what are the targets for those allocations and assessments? So we know kind of where we want to be. So when we're next looking at these figures, it's not in this place?
So some of that data will be with local authority colleagues, and I think that might be something we bring back to another session if that's right, because I haven't got that to hand, those average wait times. In terms of some of the targets, what we're focusing on at the moment is establishing what a reasonable volume of assessments is per social worker CCW, and working with our colleagues to understand what's getting in the way of that at the moment, because our number has gone down. And I've mentioned earlier, one of the possible reasons around that is to do with that, the extra scrutiny around panel. The new IT system is cited sometimes as not necessarily being over-friendly, but there'll be a number of things that play into that, all of which we can do something about. But there are going to be some targets. I think we can then run those numbers and see where that gets us in terms of our waiting list. But the other main bit of work that, again, Stephen's talked about is having to cut off the supply, if you like, of assessments which often lead to no outcome apart from advice and information anyway. Just very quickly on that, because I've got the benefit of managing services right across the organisation and into all sorts of health teams, our podiatry service was one that had been sort of perennially in this position and significantly challenged. And we took a decision 2 years ago to be very direct and honest with our commissioners, with our staff and everybody about what was actually achievable. At the time, we were still trying to meet a level of care that was actually not viable with the resources that we had in light of the demand that came in. Cut a long story short, at the end of that process, we now have an offer that is honest, that does deliver the most urgent, vital treatment to people, but also comes with a really well thought through self-help, signposting, guidance package, and it includes self-referral. So people can access all of that timely advice and information now right at the beginning. Whereas what was happening before, they were waiting a year and a half to be given that information to find out actually you don't need our service. So that sort of transformation, we've got a record of doing that in Livewell for one service, and that's exactly what we now need to try and transpose into this area, because the principles are exactly the same. What can we achieve? What's reasonable? And for people that aren't going to cross that threshold into needing an urgent assessment, what can we do to make sure that they're equipped with all of the information they need? So just very quick on the waiting. Oh, sorry.
Sorry, I've got 3 more people that want to ask questions. So I've got Kathy.
Thank you. Thank you. This question relates really to the shortage of occupational therapists. We have a lot of training in the city for medical professionals, and in the final year they go out in the community and assist. And I wonder what degree you use the students in the city.
Okay, so not necessarily specifically for occupational therapy, and I should say as well, we don't have many vacancies for occupational therapy either. So recruiting isn't our challenge particularly, it's the amount of resource we have to deploy. But organisationally, we have very good links with the university in our, not so relevant for today, but in our nursing cohort and our public health nursing actually, so health visitors. We've had nationally recognised success in growing our own locally and developing people into those roles. So those links are really well established, and we will have sort of apprentice routes as well for people that want to make that transition into OT. We've supported people to train to be OTs as well. We are also having dialogue with the University Hospitals Plymouth, nearly slipped into an acronym then, Derriford, about whether there are opportunities to look at therapy as a whole. So what can we do about looking at the role they play in the hospital? Can we start to do some rotation? Again, if we can support people at home and stop them coming into the hospital, then that's a win-win, isn't it? But those are ongoing at the moment. We haven't.
Carol?
Thank you, Chair. I was just going to go back to the clinical need is clinical need, and we get that. People need to be prioritised. But with the red, amber, green system, is there not a point where you could say someone's waited 48 weeks, we're going to cap it at 48 weeks, they'll move up the system to amber? That's what would happen in the NHS. And then secondly, if someone is given a green assessment, do they have a caseworker or anybody over them? Because to send them away and say, if you become unwell, here's CAMS leaflet. If you become unwell, here's a diabetes leaflet. To me, we have a duty of care once we've assessed them. And I would worry that we're going to, let them down at that point?
So I completely agree about the red, amber, green, and particularly the green. The waiting well policy, which I've just put up on the slide, within that will describe a transition away from that red, amber, green towards a straightforward, routine or urgent. And you're absolutely right, in the NHS, chronological booking is the norm. And that's something we have drifted away from for social care. There isn't the same sort of, there aren't the same rules around it, but it's exactly the right principle. People shouldn't be first come, first serve. It should be on that basis, excepting for urgency. And again, I think the cut-off that you're mentioning, the 48 days, that comes back to the work we need to do at our front door. So if we've only got resource to support this number of people within that amount of time, then we have to have a much clearer offer for those people that fall outside of that window, for a start. And also Stephen mentioned for people that are on waiting lists, we do have intelligence about the other services that might be being accessed, whether they're seeing a nurse or podiatrist or anybody else, to give us that little bit of assurance. And rather than a leaflet, it is a case of call back if things change. So it's not go and speak to these people necessarily. It is please call us back. But that's still not where we want to be. And the advice and information isn't sort of it shouldn't be just give you a leaflet. It should be more targeted as well to your particular circumstances as well.
So actually, once we've assessed our clients, residents, whoever comes forward, are they given to somebody to keep an eye on? Is anybody watching over them? Or is it just a matter of when you come up the list, we'll pick you back up?
So once the person's been identified as needing a Care Act assessment, so they've moved through that Live Well referral and support service, they'll then move into typically one of our 4 localities. So there is then a responsible manager whose job it is to update that waiting list. The waiting well policy, and this isn't where we are today, but this is the next iteration, starts to set out some timeframes when people will be proactively contacted. So at the front door, they'll be given realistic expectations about what to expect. It could take up to this amount of time for somebody to assess you. In the meantime, here's our number. But once that time goes beyond the limits there, so 12 weeks we're suggesting, then there is proactive contact through letters, telephone, automated emails and things like that, so that we're actually reaching out proactively. Managers are also responsible for routinely going through those lists and double checking that there hasn't been a change of circumstances, because that can regularly happen as well. Somebody can be on a list but actually they're now in hospital, or something else has changed, which means we're going to pick them up through a different route, but sometimes they can just stay there on the list if they're not tidied up. Does that help?
Murray? My question was covered by Kate, thank you, Chair, but I've got a sort of add-on. We've got a demand, we've got a clear demand, and we've got a wait, and clearly the answer lies with resource. And I think it comes a point where we can all do things differently, but there will be an end point where we can't do things any more differently, and we'll still have that demand. That's my concern.
Yes, and I share that concern, and I think that, as I was saying, that the things we can control are how we prioritise, how we safeguard people, how we make sure we're seeing the people that absolutely need us, and of course all of that is to the detriment of prevention and earlier work, which does create that vicious cycle, doesn't it?
Yeah, just to add to that, because I've worked in and observed different local authorities, and I think most local authorities, adult social care, have got problems with waiting lists and an increase in demand. We're lucky that we do have good recruitment and retention, because some places are really struggling with recruitment and retention of social workers. The Care Quality Commission are doing their inspections now, and I've read some of the reports, and they do get rated on their waiting list, but they're mainly being rated on how well they're managing the risk. But I suppose with the Care Quality Commission reports, it will send the message up that adult social care departments are struggling with an increase in demand and their financial positions. So hopefully that will raise the profile, and obviously it's something that we need to demonstrate that we're trying to manage as effectively as we can through that. The efficiencies we can provide through managing the demand more effectively, but it's also important that it's understood nationally that this is an issue that lots of local authorities are facing.
Right.
So I would suggest then that this is going to put extra demand on ED then at Derriford Hospital if you can't cope.
Well, the team I mentioned earlier, the Community Crisis Response Team, and our Discharge to Assess team, those are the areas where we've had additional investment since 2015 from the Integrated Care Board. So there's been health money, if you like, invested in the local system in social care resources. So yes, but. So yes, if there are people who are not getting timely access to preventative support that we could be offering, and those people sort of, their health deteriorates, then yes, as an overall picture, that could mean more people tipping into crisis. But when people are on the verge of that, we have an excellent timely response, which is multidisciplinary, has social workers, paramedics, nurses, OTs, physios, the lot, that works 8 till 8, 7 days a week. And then getting people out of hospital again, as we saw earlier from Stephen's data, we perform exceptionally well, and it has actually been noticed as well by the NHS regionally that we do very well in Plymouth. So yes, but the area we have had that investment has been around, it's like the ring, I sort of describe it as the ring around Derriford is quite well resourced. So accessing assessments in crisis or near to a crisis is done very quickly, in a very, very timely way. And that's really what we've done. We've put the sandbags, if you like, around the hospital. And we're very, very responsive to that urgent crisis, but it's always to the detriment of something else. And that's what you do with that finite resource, isn't it? Because you have to deal with those things. They're right in front of you now. You have to deal with the crisis. You don't have to deal with something that perhaps is longer term on the day.
But are you getting that response from the public? What's stopping me from bypassing you and going straight to ED if my wife's ill?
Well, so again, I talked about that ring around the hospital. So the other work we're doing, there isn't anything. A lot of that's reliant on GPs. And we do, this service has been in place for over a decade now, so it's well known. And our GPs regularly refer in. And so do ambulance colleagues as well. So we get about 10 to 13 referrals every day into that service for Plymouth. So it's well used. People can bypass it, of course. They can vote with their feet and go straight up to the hospital if they feel they're not accessing support, they can't get access to support they need. Once they're in the hospital, we're now doing some work with University Hospitals Plymouth on then trying to in-reach to the ED and the what's called the hot floor, so the same-day emergency care. There's lots of other environments that provide sort of same-day or near to same-day to find people and then also try and support them so they don't need to be admitted as well. We do that every day as well. So we're trying everything we can because being admitted to hospital can have really devastating long-term effects. It's absolutely essential, clearly, if somebody has an emergency. But if somebody gets caught in that hospital and stays too long in a bed, then loses their muscles waste, etc., then it takes a very long time to support that person to get independent again. And the hospital recognise that, and that's why they're working with us to try and do that.
Ian, is there anything that you particularly want to highlight from this report?
Well, I think, as we said, I wanted to be very candid and open about some of the biggest challenges. I think we've done that. There was a couple of areas. I think we've covered the final section, which was on emergency care. We've just had a conversation about that. There's some data in there that shows what I've just said, really. We're very effective at preventing people going to hospital, and we're very effective at getting people out earlier. The only area that I haven't covered, which I wouldn't mind just very briefly sharing, which I think is something to be celebrated. Oh, sorry, just very quickly. I did bring. Unfortunately, the data ends in March. I don't know why that is. We've got it up until now, but it was just to illustrate that our total occupational therapy waiting list for community have been coming down. So it's not all been doom and gloom. We have managed to reduce that, although I think it's started to rise again. So it's not, it's, whilst they're still high, we have seen that downward trajectory. But just very quickly, because this is also a service that Gary commissions us to provide. This is our approved mental health professional. So these are the colleagues, I used to be one, who support somebody, assess somebody if they're likely to need to be compulsorily admitted to hospital. And we have, I think, one of the best services anywhere in the country. So we run a 24/7 service. We have no problems with recruiting. We've got an excellent student programme. We have very low sickness in the team. Morale's very good, and we're often congratulated for how quickly we respond. And this is another area where people can also become stuck at the hospital if they've presented there. So, but as with all other things, you can sort of see a very faint line there showing that the number of people that are needing that is rising as well. So it's good news in the sense that we've got a really great team, but it's not good news for the mental health of the population, because we know there are more and more people needing that support. So that was the only other thing that we haven't covered already. Thank you.
Brilliant, thank you, Ian. I'd like to thank you for bringing this report today, and we're going to note this report, but I actually think we need to bring you back to see how those targets are doing. So maybe at another session that you'll come back and you'll bring us some more figures. Is that all right?
Yeah, of course it is, absolutely.
Brilliant, thank you.
I might bring someone else with me as well next time.
Yeah.
Just me talking.
Thank you so much. Right, we're going to go. Oh, thank you, Stephen. Thank you. We're going to go on to item 7 now, recommissioning of care homes, and we've got Caroline Patterson and Jodie Miles.
Chair, I did suggest to Ian that maybe when he came back, he brought somebody from the crisis response team with him, just to explain what their 8 to 8 service is, because I must admit, I went to visit them a few weeks ago and absolutely mind-boggled, I really was, with the things that they faced and dealt with, etc. So that might be really useful.
Good afternoon. My name is Caroline Patterson, Strategic Commissioning Manager for Regulated Care. This is Jodie Miles, who's our commissioning lead for care homes. We attended Cabinet back in September and presented a business case to ask for a 12-month extension to continue some work with our care home market. And we agreed that we would come back to Scrutiny and just give you an update on what we've done over the last 2 months with our care providers. So ultimately, this is about the voice of the service user. So we go to the next slide. So just to give you a bit of an overview, within the Plymouth city boundary, we've got 89 care homes within the city, and they're sort of providing adults of 18 plus and support and under 65 provision as well, and clients with complex needs, clients with nursing needs and residential needs. We've currently got over 1,300 adult social care clients placed in residential and nursing care, and the annual spend is approximately £50 million a year. So an update on the service specification. We've been working very, very closely with our care provider market. We've developed a specification and we've worked with a couple of other local authorities, West Sussex, Hampshire and Peterborough. I think we've got a very robust spec now going forward for our care home market. And just to remind colleagues, this contract covers Plymouth City Council and the Integrated Care Board as well. It's joint commissioning with our care home placements. So following the Voice of Our Service User programme, we've developed a vision and a value statement. And this is something that's been really, really important for us over the last couple of months. I think we've done a lot of work with our provider market. We've done a lot of work with managers and other commissioners, but we really wanted to have a focus on the voice of the service user to get their feedback and their views. So we've developed a programme to really capture that voice of the service user, and it consists of 4 different elements. So we meet on a regular basis and we have coffee mornings with our residents, and it's at a different care home every 4 to 5 weeks. And the service users all meet and have coffee and cakes. We had one last week and it was very Christmassy and lots of carols. But it's been a great opportunity to sit down with some of our residents across our care homes and just have those conversations with them. There's been a key theme around safety and what it is that's making residents feel safe within their care homes. So we're capturing a lot of rich feedback. Pre-pandemic, we also had a programme with Health Watch. And what Health Watch did for us was they went into care homes and they listened to service users and they captured their stories, and they went in independently to try and, you know, find out what was important to residents living in a care home. So we've got the Health Watch programme starting again. Unfortunately, there's been a bit of a delay, so it's not going to start until January. But again, independently, they will go in and talk to residents within our care homes, and then they'll share that with our commissioners. We've been attending residents' meetings, so Jodie and Rob, our colleague who's sitting at the back, we've gone into care homes from a commissioning perspective. We've spoken to families, we've spoken to residents, we've attended their meetings, and we've asked some really sort of specific questions again around the environment, the staffing, what's important to residents. And then we put together a resident survey. There's about 12 questions, and again, it covers some very, very key themes that really will help to support us to sort of really capture what are the most important elements to providing care within a care home to people that live within those care homes. So what we've learnt so far, and we're still getting questionnaires in, and one care home, just to share with you, we had 51 responses. And just to give you a bit of context, some of the residents didn't choose to answer some of the questions. So it's really, really important that this has come from residents and they're being very open and honest about what's important to them. But the key theme that has come up is family. And the overwhelming response from everyone that we've spoken to is that they felt that that was the most important element to them. If their family were welcomed within that care home, then that was absolutely amazing, and it was really, really important. Staff, residents told us, you know, how staff, their kindness and their caring natures, and how that positively impacted on them. And one resident said how she loved to hear staff laughing in the kitchen and how it sort of brightened up her day. Personal possessions was another area that people felt really helped them to settle into their care home. It made it feel homely. And I think I shared at Cabinet, but certainly one of the residents that we spoke to wasn't able to attend a wedding, but they actually celebrated that with Skype, and they had the sort of menu, they dressed up and just made it a really big event, even though the resident wasn't able to attend in person. So personal possessions, and we are still capturing more and more feedback coming in. So the vision statement, I won't read it through the vision statement because we have one of the residents who's going to read it out at the end to share with you. But this vision statement will now have a key focus, and it will be the first thing that people will read in the care home specification. So we found our specifications become very task orientated, and it was really important to capture the voice of the service user. So you will see that they talk about
their independence being supported, treated with dignity, a homely environment, values and cultures are supported. But as I say, I won't read through it because we have Glenda reading the vision statement at the end of this presentation. So next slide. So just to give a bit of a market update, we've got dignity forums that are ongoing. We have our next forum, which is tomorrow, and I think it was Councillor Penrose, you were saying about the modelling earlier on. So everything that we've done with the care home market around remodelling, what does it look like? How are we going to manage capacity? How are we managing the complexity of needs? So we aim to do exactly the same with domiciliary care and our supported living providers as well. And it really has taken quite a long time to work with our providers to say, you know, what does our care home market look like? What does capacity look like? What does staffing look like? The environment. So it's taken sort of virtually 12 months to really define that model for care homes. And we intend, as was mentioned earlier on, to do the same with domiciliary care, to start looking, what does it actually look like? Where do we need to diversify? Where do we need training and those elements really? So we didn't find that during 2022 and 23, we did have a series of care home closures, but that seems to have settled during 2024, but I'm going to touch wood, and we're going into December, but fingers crossed that seems to have settled. And just to say, you know, which is really quite important, again, that the older persons residential and nursing placements, they continue to be made at Plymouth City Council's banded rates. So that's really good news. And as I said earlier on, Health Watch are going to start their programme in January. So just again, some stats. We had just over 8,000 new clients requesting adult social care support during 23-24. Over 4,000 people access long-term adult social care support. Over 1,300 in residential and nursing care, and 24/7 hour care in residential or nursing, circa 1,000 people on a day-to-day basis. So that just gives you a bit of an overview of the current market. Well, wanted to share with you care home quality really and what that is looking like. And, you know, for us in Plymouth, the overall care home shows 86% of Plymouth care homes were rated good or outstanding. So we are favourable in outstanding and good, and we are certainly just under the national percentage for requires improvement. So we hope that continues and continues to improve. So next steps for us are we need further market analysis of the current supply and demand in the market and a clearer narrative around capacity. So we're doing some further work around that. We want to use that market analysis to really develop our agreed procurement process. So that will be the next stage for us for care homes, to decide what are we going to procure, what type of procurement process we're going to use. So those will be our next steps with our provider market. And we just want to continue to capture the service user feedback from the questionnaires and the responses that we've had. So the questionnaires are still coming in. We're still attending coffee mornings. We're still attending resident meetings. And as I say, this is from families, relatives and service users. And for us, from a commissioning perspective, we cannot do this without the voice of the service user. So as I say, we've done a lot of work with providers and other colleagues, but this is really crucial to help us to ensure that the model that we develop going forward for care homes really meets what service users expect and residents expect when they're living in a care home. So I think we go to Glenda now, who is going to read out our vision statement. And Glenda is 87 years of age and lives in one of our local care homes.
This is how I feel living in a care home. a care home that is my home, where my family, friends and loved ones are welcome, where my voice heard and listened to. My health needs and independence are both supported. A home where I am treated with dignity and respect, and where my individual values and cultures are supported. A home.
Okay, I mean, we can always go back to the video. What we can do is we can go to questions. Um, I've got a question. So, got 89 care homes. Can you tell me how many took part in the feedback from your and what you ever did your survey? How many of those care homes took part? Was it every single one of them?
So we are still receiving feedback, but I would say a good 2/3 of the market have responded either via a questionnaire or via where we've attended, because we've certainly attended about 13 amongst us as well. So, but the feedback is still coming in and the questionnaires are still coming in.
Okay. And do we know how many residents took part?
Well, as I say, one of the care homes, we had 51 responses, and that was the majority. That was 51 out of 64 residents, I believe, Rob. So they all took part. Some of the families also responded, and certainly when we visited, we met with families. Some of them were, so some of the feedback, Councillor Murphy, was from residents' meetings that we attended. So quite often there were maybe about a dozen residents. So we are going to continue to receive feedback, but we would like to think that we get feedback. We've got a forum again tomorrow, which will prompt, we'd like to think that we get feedback from the majority of the 89 care homes.
And can I just ask, you've got on this report that the quality standards of Plymouth's overall care homes shows 86% of Plymouth homes were rated good or outstanding. Can I ask, when these reports are done, are the care homes notified beforehand that somebody is going in to give them a rating? Or would you just turn up, or somebody just turn up on the off chance and then just do a little bit of a rating? Or do the care homes know when they're actually coming?
So CQCs are the regulators for care homes, and sometimes they will do unannounced visits, or sometimes they will announce those visits. What we do, Councillor Murphy, is we actually meet regularly with our CQC and our local inspectors. If we're looking at the homes that are inadequate or requires improvement, what we have is we have a provider of concern report where we will have care homes that we perhaps might have some quality issues or safeguarding. So we actually share that intelligence with the regulators. It might be that we feel that actually the regulators need to go in and do an inspection, but that is managed through the Care Quality Commission, and as I say, some are announced, some are unannounced. If we've got quality and practice concerns, we've got some colleagues who are quality leads within our safeguarding team, and they will actually go out and again they'll do unannounced or announced visits in respect of quality and practice that's been picked up.
Okay, can I just ask how often as a local authority do we visit these care homes?
So we don't have a programme of regular visits, but going into the new year, because we've gone through a restructure and we've sort of reshuffled as a team, a regulated care team, we've got domiciliary care, care homes, some supported living, children's placements and fostering within our portfolio. So we will have a plan of contract meetings going forward. We meet with our care home providers every 4 to 6 weeks through a forum. We meet with our dom care providers again 6 weekly. Depending on we have an intelligence dashboard, and depending on any concerns that are raised on that intelligence dashboard, we will prioritise as commissioners if we need to go out and do an urgent visit. So that's how it works at the moment. And again, we work very closely with our safeguarding team. And if there are any concerns, we might do joint visits. So it depends on the severity, if you like, or the priority for us. We can go out any time of day, really. But we don't have, with 89 care homes, we don't have regular contract meetings. But going forward, we intend to have something that's a bit more. We used to do quality reviews, but we'd like to have something that's a little bit more focused in respect of managing those services.
And can I ask, so if I was, or I had a concern and I reported something, would I, so it was reported to Quality Commission, and would I get any feedback from them of their findings?
So if you can raise a concern with the Care Quality Commission, with CQC, and they should feed back to you, often they might refer it back to commissioning and say, we've received a concern, can you look into it? If there is a concern in relation to, so as commissioners, we're commissioning the service. If there is a concern in relation to commissioning, and that comes to us in commissioning, we will certainly feed back to you. If it's safeguarding, it will go through the safeguarding pathway. And again, we work very closely with our safeguarding team, so we share that intelligence amongst us. But you should get feedback from all 3 of those pathways.
Has anybody got any questions? Oh, sorry. Kate.
Thank you, Chair. It's nice to see some enthusiasm for reshaping the commission of care homes. So hopefully long gone are the days where people were shoved in a care home and forgotten about. I think it's the focus on remembering and realising in everything that the local authority does that care homes are people's homes is really important. So it's nice to see that message reiterated. Also very good to see 86% of our care homes are rated good or outstanding. You know which percentage my question is going to be about. It's the other 14%. How weighted is this recommissioning exercise towards improving the outcomes of those care homes as opposed to those that are good or outstanding?
So I think, Councillor Taylor, our specification has been completely reviewed and updated, and it certainly feels like our spec is much more robust. And I think that will give some key messages to the market. I think we've been very lucky in Plymouth because we have good relationships with our care home provider market. So what we will do through the forums, and it's something that we've always done, is we will try to share that best practice through the forums. So pre the pandemic, we used to have wraparound support workshops. We used to have preparing for your CQC inspections, and we used to have a leadership programme. Those 3 elements we are trying to get back onto the radar because CQC inspections, can frighten a lot of providers. They're not always prepared. So we really want to help to support our provider market pre an inspection. But also what we're trying to do is, so last year I wrote a policy that was about commissioning for quality assurance across all of our services. And in that, it actually describes the roles and responsibilities of every single person, so the provider, CQC, commissioners, and people that sort of have our services. So I think, again, that's been really helpful for us to really understand when we talk about quality, do we actually know what that means? Have we got a joined up approach? Are we working collaboratively in respect of when we talk about we want to improve quality and quality standards, that actually this policy really helps us to understand that. But what we're trying to do is not wait for those services to get to requires improvement or inadequate, but actually what the preventative you mentioned, what are we going to do in advance of that, pre us ever getting to that stage? Because it's a lot of work when we've got services. So that's what we're going to try to do moving forward, is just to do that proactive work. At the moment, the last 12 months have been taken up with the modelling and the shaping, but going forward, quality improvements, CQC compliance will be key for us going forward.
That's really good to hear, because it's cultural change in a lot of care homes, and that 14% will need, aside from everything else, a cultural shift. Is your goal in the recommissioning of these services 100% at good and outstanding? Is that something that's written down somewhere?
It would absolutely be our goal, because there should be no reason ultimately that we shouldn't have services that are all good and outstanding. So we will always strive towards that. There will be circumstances for providers. It's been difficult and it's been challenging for our provider market. And there are still some consequences of the pandemic and some of the challenges that we know are around for that market. But from a commissioning perspective, we will always endeavour, we have to share the resources we've got, we have to share the best practice, and we have to work collaboratively to support each other through that. So yes, 100%. I will come back when
Some of them are waiting for inspection as well, aren't they?
Yes, and I think that's the other bit. So some of these figures will be services that are waiting re-inspection, which again is just, doesn't give a true reflection. But I will definitely come back when we've got 100%. I'd be more than happy to.
Kathy?
You've got a figure of 50 million as the amount that's being spent on residential and nursing care in your homes. I don't expect to have a breakdown at this meeting, but for a future meeting, it would be very interesting to know how that was broken down and how it was broken down between homes.
Absolutely, and certainly we can do that for you and bring that to a future meeting.
Thank you.
Absolutely.
Carol and then Lauren.
Thank you, Chair. Just two little questions, really. It makes me immensely proud to see that 86% of our care homes are doing really well. But can you give us a figure from 5 years ago where we was? Were we 70%, or just for gauging how we've grown, really?
I would say, actually, looking at the figures over the last 5 years, it's been fairly consistent in respect of that 80% figure. I would have to check beyond 5 years, but I think it's been fairly consistent.
So it's grown.
Yeah.
Yeah. And the other thing is, the resident survey is a brilliant idea, but to get a full 360-degree picture, you should also do a staff survey, because each staff in those residential homes works for an individual company, and every company runs them differently. I mean, I'm a nurse, I know, worked in the homes, and it'd be great then to see that if the residents are really seeing the whole picture, or if there's something hidden. Thank you.
Absolutely, and we'll take that on board, because it is another part of the jigsaw, isn't it? And really important, but we'll take that on board. Thank you.
Thank you, Chair. I was really moved by the vision statement. I thought that was beautiful to see. My question is again on those that are in the needs improvement category. Are there any through lines in those reports that we're taking learnings from? And also, have we made any particular attempts to get more feedback from people that are staying in those facilities and their friends and family? 'Cause I wonder if their responses might be slightly different to those that are marked good or outstanding.
So in respect of themes, so what we often do is we will look at those services that requires improvement. We will look at the services that are providers of concern. At the moment, the only theme that we're finding where a provider might be high risk is because they haven't got a manager in place or they're carrying lots of vacancies. We've not seen any really key themes across the market, but when we do, we will then have a session at the forum. So a couple of years ago, we were noticing a theme around meds management and some of our services not following NICE guidance. So we ran a couple of workshops. So it will all usually be brought back to the forum if there are themes. Again, we'll look at whole service concerns with our safeguarding colleagues, and if there are themes cropping up there, we will cover that through our dignity forums with providers. And then, sorry, I forgot the second part of your question.
So the second point was, have we made any particular attempts to get survey responses from those in the kind of needs improvement settings?
So just getting more feedback from requires improvement providers. It's with 89 care homes, it's quite a big portfolio, and in fairness, we would probably say that we worry about the providers that we don't hear from. So that is a piece of work that we would like to focus on next year. What are we doing about the providers where there's non-attendance at our forums or our workshops? Because again, that you don't know what you don't know. So as I was saying earlier on, we want to go back to the wraparound support workshops. We want to get a bit more intelligence. The services that are isolated, if you like, or not really connecting with us. But that will probably be a key piece of work going into next year, really, for us to have a focus on.
Do we see any correlation between the needs improvement and the services we're not hearing from?
There is an element that the two are linked. And I suppose there's also an element, so if you take our care home market, although it's 89 care homes, they range from a 1-bedded care home to a 64-bedded purpose-built care home. So sometimes it's the smaller homes that we're seeing that are sort of struggling a bit, and we know that we need to do some more work with them.
Thank you so much, Caroline and Geordie. Thank you so much. This report was just for noting, but I think at some point we really do need to bring you back, just to see how we're going, to see if that 86% is gone above 86%. But it's interesting actually to see what you're actually doing. So thank you for coming and doing this presentation. Hopefully we'll see you again soon. Thank you. Item 8 is 1 Devon ICS Finance Report, and we've got Bill Shields. Is Bill online?
I am. Afternoon.
Afternoon, Bill.
So, if it's okay, I'll assume that you've had a chance to read the report. And apologies, last time there was a problem with the mic and I couldn't hear anybody. So this is slightly out of date. What I'll do, if it's okay, is to just describe the content of this report and then give you an update on where we are at month 7 and at month 8 in terms of the financial position. So this report sets out the position for not only the Integrated Care Board, but the whole of the integrated care system. So that's the combined position of the ICB and also the 3 acute providers and Devon Partnership Trust within the Devon locality. We submitted a deficit plan to NHS England, which was back in April of this year, and that was a deficit plan of £85.4 million. After discussion with NHS England, and like many ICBs, that position was revised to a lower deficit plan of £80 million. And we've been monitoring the financial position against that revised position since month 2. We've managed the £5.4 million adverse variance to that we were informed of through a system risk share. So that means that the ICB and each of the providers manage that position. I'm pleased to say that as at month 8, we managed to resolve that position, and that risk is not something that's currently within our financial position. We have also received at month 6 deficit funding. This is not unusual in the NHS. So those organisations who've set a deficit plan then receive cash to support the funding of that deficit, and we received £80 million of cash in month 6. And so what we're now forecasting as a revised position is one that's a break even. So just to explain that in case that's not clear, 85.4 became 80, and then we received £80 million of cash from NHS England, and that allowed us to move to a balanced position for this financial year. At month 6, we had a slight adverse position against that £0.7 million, and that reflected the residual unfunded element of the industrial action that we saw in this financial year and in previous financial years. But at month 8, we've been able to resolve that position. So we're now forecasting and are currently at a break-even position. We achieved £66.6 million of efficiency in the first 6 months of the year. The forecast, like many integrated care boards, is heavily back-ended CIP plans. So the full year impact is £213 million. That compares to a very similar level in the last financial year, which was just under £210 million. So each year we're required to make significant cost improvements across the whole of Devon. During planning, we identified risks of £88 million. So those were risks over and above that deficit position. And we mitigated £17 million of those. We're now at a position where we have managed to mitigate the majority of those risks. And the forecast at month 8, notwithstanding the fact that we've still got 4 months of the year to go and that our cost improvement is back-ended, is that we will achieve the plan. We will achieve the revised forecast position of a break-even, but it will be extremely tight. As we exit this financial year and go into the next financial year, our underlying position is one that continues to be a real cause for concern. We entered this year with an underlying position of just under £160 million, and the likelihood this year is that that will increase to a position closer to £200 million. And the reason for that is, although we are planning to deliver the financial position, again, like many organisations in the NHS, we've seen that more of the plan is being delivered non-recurrently than recurrently. And by that, I mean things that we can do once rather than every year, technical accounting changes, transfers from revenue to capital, and those sorts of things. So they will actually improve the position in year, but they mean that the position as we exit this year and go into next year actually continues to be a real cause for concern. The integrated care system has developed a medium-term financial plan, and that's one that covers the position in the current year and then takes us forward over the next 4 years after that. And the plan is to reduce our deficit position from the £80 million this year to £75 million the year after, £50 million the year after that, £25 million the year after that, and then return to a break-even position as an integrated care system in 29-30 rather. That will require significant savings to be made across the system, and we have developed and started to implement a system savings programme. There's a transformation programme that includes a number of large-scale strategic savings programmes, and each of those savings programmes has a senior responsible owner and a sponsor chief executive from one of the organisations within the system. We forecast that we will deliver at least £160 million from those system-wide savings, but that is still only a small fraction of the level of savings that we'll have to achieve every year. They'll continue to be in the region of £200 million plus, reducing to 170 million, and then finally getting to about 125 million pounds when we achieve a break-even position. So we have a significant financial challenge, as does the whole of the NHS. I would love to say that the monies that were announced in the budget would solve this problem next year. I think early indications are that when we take into account the impact of the national insurance changes in those areas that are not exempted by the government, then we'll see a significant element of costs passed through to NHS providers and other NHS organisations. The funding that was announced in the budget also has to take account of any pay awards that are announced by the peer review bodies next year. And just to give an example of the impact of those, every 1% is equivalent to £1.3 billion across the NHS. So again, significant amounts of money. And then finally, the impact of reducing waiting lists, what we call our elective recovery fund, also has to be funded from the settlement that the Chancellor announced in the budget. And again, that will be a significant impact. And so I think the most likely position that we have forecast going from 24/5 into 2025-26 is a real terms reduction in the available monies that we have. So there might be a nominal increase, but that will be a below inflationary increase. And that means that the savings programmes that we're currently undertaking, the approach that we currently have in Devon, and the pressures that we currently see are likely to continue for the foreseeable future. At that point, I'll stop. I'm sure there will be questions, and happy to elucidate any point that's not clear or answer any queries that the committee may have. Thank you.
Thank you, Bill. I mean, obviously, there's loads of savings that you've got to make. How are you going to do it? Are you going to be cutting services to make these savings?
Well, I think that that is something that we will look to avoid. Just to be clear, the ICB's position is one that's a coordinating position, and the programmes of savings that individual providers and their boards sign off will be an issue for their boards. We will need to be assured that in doing those, there isn't a patient safety impact. Every savings programme is required to be accompanied by a equality impact assessment. And the purpose of that is to ensure that patient safety is never compromised as a consequence of the savings programmes. One of the things I would say, though, in the current climate is that safety is absolute, and we really need to be clear that we will never compromise patient safety. But quality is relative, and so there will be levels of quality that can be delivered for the available funds. That doesn't mean to say that we're looking to provide poor quality services, but there will definitely be different levels of access, different levels of quality, depending on the funds that are available. Each of the organisations will have its own cost improvement programme. We haven't ruled out, and in the case in some organisations in Devon, it has been possible to increase their income base, so increase revenue, particularly from the elective recovery programme. Royal Devon University Hospitals has been quite successful in this endeavour, mainly because it has protected elective capacity in the Nightingale in Exeter, and that allows it to do more elective work, not just for its own patients, but also for the benefit of the whole of Devon. So we are in a stronger position than many other systems across the country to try to find ways to earn our way out of this problem, as opposed to just looking at cuts in the current level of expenditure. But to be really clear, the feedback that we have received and the narrative from NHS England this year and going into next year is that we need to continue to bear down on workforce costs. We need to continue to bear down on headcount. And the latest discussion that has been had is to focus on those non-clinical facing administrative, managerial and clerical posts, because they have increased significantly from the pandemic to the current position.
Thanks, Bill. I mean, I don't know how you're going to make a system work without staff, so that just seems crazy. But hey, I've got Will, and then I've got Ray, and then I've got Ange.
So could you give an example of a recurring saving and an example of a non-recurring saving? Because it mentions this. What's an example of something they've achieved that's a recurring saving? Examples of it's a non-recurring.
So a recurring saving would be where we came up with a new process and that allowed us to either through using, say, for example, a digital process, reduce the number of staff that needed to be employed. So that doesn't necessarily mean that we would cut the number of staff. We could redesign job descriptions, redesign role specifications, and move from processes that are manual to processes that are digital. So that would be an example of a recurring saving. An example of a non-recurring saving would be where between now, say, and the end of the year, we held vacancies because that would allow us to achieve this year's financial position, but we would then need to recruit, say, in the beginning of April. So we'd improve this year's position, but we wouldn't get a benefit going into next year. And equally, a technical accounting feature that we might look at would probably be non-recurring. So if we were to look at relifing assets, say, that's unlikely to have a recurring benefit. In theory, we should be looking for, and we always strive to go for recurring savings. The best position that we'd like to get to would be 80% recurring, 20% non-recurring. The latest information that I have is it's about 63-37 in Devon. That's not unusual, and compared to the rest of the country, that isn't bad. But if we are to tackle the problem that we've got and do that in a sustainable way, the level of recurring savings has to increase. Often, the reason that recurring savings are as low as they are is that we start the process for reduction in spend very late. And so those plans that we have, which might be great plans, don't get implemented in the time frame. And those recurring savings then have to be substituted by non-recurring. And non-recurring savings are almost always not planned. So again, there is an increased risk in terms of the impact that they will have on service provision.
I've got another question about a different.
Well, I'm going to go to Ray then.
Right, and I'll come. Yeah.
Good afternoon. Can you tell me what your policy is going to be as regards to the utilisation of NHS professional augmentees to fill gaps in staffing levels at Derford Hospital, please?
So the plan will be to utilise NHS professionals as opposed to using high-cost agency. So we should always look to recruit permanent staff. Once we've exhausted the possibilities of permanent staff being employed, we should look at bank processes, and NHS professionals provides an efficient way of filling those bank posts. That doesn't mean to say that it's successful in every regard, but it provides a much cheaper source of labour than many of the high-cost agencies. We are and have been very successful at reducing reliance on what are known as off-framework agencies, so a number of agencies who charge rates that are significantly higher than the agreed rate card in Devon or indeed across the English NHS. And NHS professionals does provide us with the ability to do that. But in the first instance, we should always look to recruit permanently because that is the lowest cost solution.
Angela?
Thank you very much for your presentation, which I'm sure you know came over as, quite worrying. And one particular worry I would like you to explain, one I have. You talk about this distinction between safety and quality. And I think I understand, but I just wondered what you could you give an example of where your quality might be at a different level, is what you said?
Yeah. So my distinction would be that, as I said, I think safety, I believe safety is absolute. So in a quality equality impact assessment, that will assess the choices that an organisation needs to make between finance on the one hand, operational performance, so waiting lists, the time that patients wait in the emergency department, and then the impact on the quality of the service that's provided. Safety is something that can't be compromised. That's something that the Care Quality Commission would take a very dim view of, and it's something that really absolutely clear cannot be compromised. But there'll be levels of quality that can be provided in terms of the available resources. So we can improve access and reduce waiting times if we have more money. So I would argue that having fewer patients waiting, having patient, and whether that's in the ED or whether that's in those patients waiting on elective waiting lists, that would reduce based on more money being available, and that would be a qualitative improvement. So that'd be an example of something where there's higher quality, whereas safety would be one where if the position with patients, say at the ED, was such that that their life was threatened or that there was physical harm that could come to those, then that would be something that couldn't be tolerated. So I think there's a distinction in my mind between safety and quality. I don't know if that helps to explain.
I think, yes, it does. Thanks a lot. Thank you.
Welcome.
Will?
On another part of the report, you've got the capital spending. So you've got for it says system capital, including the impact of IFRS 16.
Yes.
Could you, a two-part question, just define what that means, and
yep.
Does that mean, so when you look at the line for Derriford Hospital, it's saying it's forecasting a spend at the end of year 49 million with a 5 million variance. Does that mean that there's does that mean that things have been rented instead of purchased, leased instead of purchased, or does that mean that capital expenses like new equipment or new facilities have been pushed back or postponed for one reason or another? Thank you.
Yeah, no problem. So IFRS 16 is a change in accounting practice that came in a few years ago. It's only just being implemented across the NHS. And what it does is it says that those assets that were previously leased must now be defined as being capitalised. And Derriford, not unlike many hospitals, has leased assets in the past because it was a cheaper form of procurement than actually buying them outright. That's now very, very difficult because what IFRS 16 says is that you need to look at form over substance. And if you have an asset that is essentially one that you use and that you have taken ownership of, whether you've leased that or whether you've purchased it outright makes no difference. And so the variance that you're seeing there is the change that has occurred as a consequence of reclassifying those assets that were previously leased under IFRS 16 and then charging them against the capital programme. That means that Devon has an adverse variance when it comes to IFRS 16. It's a technical issue, and in discussion with NHS England, we've been very, very clear that because there's a technical change and that change has happened during the course of this year, we are not planning to reduce capital spend as a consequence of that technical change. So that's our current position. I have not had any pushback from NHS England that that will be a problem between now and the end of this financial year. I think going forward, though, it may limit the system capital that we have. And it's something that we will continue to raise as a problem, because what should not be the case is that the access to capital to improve service provision across Devon should be dictated by accounting rules. That just doesn't feel right at all to me.
So supplementary, Will.
So when you look at the UHP's, the capital thing for last year, the capital programme on their website, it says the total programme was 114 million, and 44 million of that was capital leases, and the rest was, so that it's to do, so it's not that any of these things in this year, things similar. I mean, last year there was all sorts of items on there, you know, the REI, the LINAC, which is the radiotherapy bunker, all sorts of large, you know, these are, you know, things that when we work there, we see this equipment being used and utilised to improve the services for people and make things more efficient. So this wouldn't, this is like an accounting change. It wouldn't affect it wouldn't affect these things actually happening.
I think that there is a risk
added on.
that this will affect things going forward. That I'm not going to try and pretend that there isn't a risk going forward. So the way in which they have been categorised is a problem. We've done a review of system capital across Devon, and capital is extremely limited. We have heard that in the budget, it is possible that capital allocations will be increased for the NHS going forward. I really don't know what the impact for NHS Devon will be, or indeed for UHP in the Plymouth locality. What I do know is that the availability of capital that we have in Devon, based on its current level, is unlikely to sustain the significant and major expenditure that we have, particularly in terms of expensive medical equipment, so CT scanners, linear accelerators and the like. We will be unlikely to have all of the capital that we need to replace all of those assets going forward, and we will need to be really clear about what that means for the population of Devon and what that means in terms of the pattern of service reconfiguration and configuration. It might feel a bit like the tail wagging the dog, but the availability of capital is something that's absolute. We will continue to make approaches to NHS England to ensure that system capital is something that is available, because it is a major enabler, not just in terms of service provision, but a lot of the changes that we want to make that will reduce cost will require a capital injection up front, or in some cases a revenue injection. I don't think it's realistic to expect the size and scale of the challenge that we've got in the savings programme that we have without actually looking at some pump priming, whether it's capital or revenue. So we'll continue to make representations to NHS England going forward.
Okay. Thank you, Chair. I'm looking at page 8 of your report, the workforce part. I am less of a numbers girl, more of a people and politics girl. So could you just, before I ask my question, so as I know that I'm correct, is that table saying that in terms of substantive workforce, the forecast is to be 6 billion overspent?
Yep, the current position is that we will have an adverse variance, even though we've seen a reduction in workforce. But that position has improved since month 6. Each of the organisations in the system has continued to bear down on permanent, but particularly bank and agency, high cost agency and locum staff, to ensure that we get to the level that is required. And it varies across the system. Part of it is also skewed by the fact that in some cases where the workforce is increased, that's offset by additional revenue. So again, in terms of the reduction in waiting lists, in some organisations, employing additional staff to reduce waiting lists is much better than that work being outsourced or that work being insourced. So it's always a better solution to employ permanent staff, and that's one of the things that we've really focused on.
Yeah, I don't necessarily disagree with that, but I think I would have been less concerned, not content, but less concerned if those figures were just in relation to bank and agency. But if the trusts aren't sticking, like how have we got to a situation where trusts are recruiting over their agreed budgets for staffing? I run a staffing budget. If I don't have the money to employ someone, I simply don't employ them. And so if the numbers were for bank and agency, I could understand that a bit more, because we know that we need staff to get us out of a hole. There are crises that happen, you know, we've all seen them in the last 5 years alone, as to why that might be necessary. Yep. But substantive staff for me is different, and I would be concerned in I want to be able to have confidence in these trusts' abilities to work their way out of these issues with their numbers. But if you can't stick to budget on one of the things that you can, you know the numbers before you recruit someone, how can I be confident in their ability to manage the things that they have less control over?
So it's quite a complicated and complex issue, and there isn't really one answer to the issue that you've highlighted, and it's a very, very good point. So although Devon is a North 4 system, so it's in National Oversight Framework Segment 4, the ICB and the 3 acute providers are in North 4, which means that they've got significant controls over recruitment. So every discretionary post has to go through what's known as a double and triple lock process, and every post really needs to be signed off in an individual organisation, or in some cases at a system-wide vacancy control panel. Complicating factors are that Devon Partnership is not in North 4, it's North 2. And so the controls don't necessarily apply to that organisation, and it can recruit and it can increase its workforce, and it has had quite a significant reliance on banking agency usage during the course of the year. So that's one issue. The second issue is, as I said before, in some organisations where they're increasing the level of workforce, the level of activity, it does make sense for the workforce to increase. Because if the revenue is greater than the cost of delivering that revenue, then that is something that makes eminent sense. And while we've got workforce controls in place, the overriding thing that we're focused on is ensuring that we achieve financial balance. So that's a complicating factor. But the third one is that it would be wrong of me not to say that the workforce controls that were in place in the system were not adequate during the first part of the year. And despite some of the assurances and reassurance that was given in the system, we saw workforce continue to increase in some organisations. And so while it was fairly static in some, in Torbay and South Devon, for example, there was a continued increase in workforce. So what have we done? We've reinforced the controls. All of the chief people officers, as well as chief finance officers, are involved in monthly and more regular meetings to ensure that workforce controls are adhered to. No post can now be recruited to in those organisations unless it's gone through a rigorous process in the organisation and also externally. Now, will we get back to the target? I think that's unlikely, but have we actually seen an improvement in the run rate since the workforce controls have been strengthened? Yes, we have, and that should put us in a much better and much stronger position as we go into next year.
Thank you for your honesty.
Carol?
Thank you, Chair. You did touch briefly on waiting lists, and so from what you said, we do have a problem with quality and funds. And I know that you mentioned the Ardenia and Nightingale, and they have a policy at the moment to insource and use their own staff and pay their staff lucratively to do waiting lists every weekend, clearing a backlog. It's very successful. It's bringing more money to the trust. Can we have something like that for Plymouth? Can the funds be available for Plymouth? Can we bring the lists into Plymouth? And I know it's come provisionally from an outside company that was formed in Bristol, which was helping to clear all these lists and everything. But that is fundamental, improving staff morale, keeping staff. They don't go on agency, they don't go for the higher rates, and also clearing the backlog. Is that something we could look at for Plymouth and not just for Bristol and Exeter?
So the short answer is yes, but like anything, there are a couple of caveats. So insourcing is successful in busting the waiting list in a short period of time. It's really important, I think, though, that we look at that quite rigorously. So for those that don't understand or not familiar with this, what insourcing means is that consultants that work in the NHS often will set up private companies, and those private companies will do the work to clear the backlog, and they'll do that at a level that is below the tariff set for that work. That money will then be shared between all the staff who are participating in that process. And so some of the things for me that are really important in terms of rigour are how often are the contracts with these companies reviewed. And I'm not saying this in the case of either RDUH or in the case of UHP, but in some cases across the NHS, contracts have been awarded and then they're extended, and then there are single tender actions. And so it's really important, firstly, that commercially these things are kept under review. Second thing is that any consultant who is participating in insourcing, he or she has to satisfy their core NHS contract. And I think that's really, really important. I think that's really important morally and ethically, that in order to be able to qualify for this, they should be satisfying that. And I'm not saying that there is any instance that I'm aware of where that's not the case, but I think we would expect that's something that would have to be put in place. And the third thing for me is that there is some evidence that in terms of the work that tends to be done by companies that insource, it tends to be high volume, low complexity work. And again, it's really important that what is left within the NHS isn't the really, really complex work that takes a considerable amount of time. The impact of that will be that NHS internal productivity will reduce, and what will happen is that a lot of the activity that's done by the insourcing companies will be creamed off. And that's something I think that organisations need to be really, really clear about, and they guard against that. To your point, there is nothing stopping UHP doing this, nothing at all. And in fact, the ICB has encouraged them and other providers in Devon to follow RDUH's example, to talk to them, to learn from them, to find out how they've made this work, and to look at ways in which that can be done across the system. So we absolutely advocate that. What you've suggested is something that we have been pushing very, very hard for the majority of this year. And I think it would be to everybody's benefit, provided those safeguards that I highlighted at the start are in place.
Thank you so much. Thank you, Bill, and thank you for your report. And hopefully we'll see an improvement in the near future. Thank you.
I hope so. Thank you very much. Thanks a lot.
Before we go on to item 9, I have to go by 4:30. So Kathy will take over the chair for me. So at this point, I'd just like to thank, because I'm going to be gone, thank Elliot and Gary and Mary for all their hard work that they've done throughout the year, and also the committee members, because I think you've been excellent in asking questions throughout this year. And I'd like just to wish you all a Merry Christmas, and I'll see you in the new year. But I'm not going yet. I'm just going at 4:30, and I didn't want to interrupt our two ladies. So anyway, so we're going to go on to item 9, which is maternity care report, and we've got Natalie and.
Hello, Pauline. Hello, Chair.
Thank you.
I'll just kick us off. My name's Amanda. I know I've seen many of you before. Thank you for inviting us today, Chair. I'm with my colleague Natalie. You've asked us for an update on maternity services in relation to the Care Quality Commission inspection we had, but that was back in March 2023, which is almost, can we believe it, 2 years ago. So in discussion with our maternity colleagues, we felt it would be really helpful to give you a more up-to-date picture of where maternity services are using what's called the MINAP framework, the Maternity and Neonatal Improvement Programme framework, and that's a national framework. So Natalie's just going to run you through that. We're really, really aware that the NHS uses lots of acronyms and that the presentation in and of itself is quite hard to understand. So Natalie's going to run through it with us. Just to say, Chair, before we start, if you want us to come back and talk about capital developments, for example, you know, we've just heard from Bill, haven't we, on a very, very tight financial situation, but I think it's also really important to point out that Plymouth has had considerable investment in terms of the Community Diagnostic Centre worth over £25 million. We're just about to open in the spring a new urgent treatment centre, which will be located on the Derriford site. Important just to put it in that context that Plymouth has had considerable investment. Okay, so I'll hand over to Natalie.
Thank you. Good afternoon, all, and thank you for inviting us today. Just to give you a little bit of background as to who I am. So I'm a midwife by background of 15 years, and more recently been asked to come and step and support the Trust in relation to the Maternity and Neonatal Improvement Programme. So I'm the lead for that, and incredibly proud to be such. essentially, as Amanda has said, our CQC inspection was in September 2022. They very kindly gave us 8 must-do actions and 4 should-do actions, of which we've provided substantial evidence to be able to mitigate against those and be able to be signed off of that plan. What I wanted to do today is just to talk to you and give you a really current position as to where we are. That's really, really important because we've moved on substantially from then. And if I may, I want to start with some huge successes because we need to celebrate our excellence equally. Namely, the development of and the opening of our bereavement suites. We've got a dedicated bereavement suite now at UHP, which is absolutely huge. Huge not just within the region, but nationally. We're still finding that trusts nationwide don't have this facility. They don't have the ability to nurture and look after these families that experience loss. So if you haven't already, then I'd really urge you to come and look at the facilities we've got at UHP because they are absolutely beautiful and absolutely support our families that go through loss. Another big one is in relation to the implementation of a national tool called BSOTS. It's a Birmingham symptom-specific triage system. In the absence of national direction, we're expected to make sure we provide women with urgent and emergency care when they come through the maternity department. But nobody absolutely outlines what the expectations are. So we had to go network, benchmark and see what the excellence looked like and then be able to bring that back. We've had that in place now for 12 months and seen a massive improvement in what quality looks like for people that are emerging and coming to us for that care. And then finally, I think that it's no secret we've had some really quite significant cases where we recognise that documentation and the appropriate systems in place have fallen below the adequate level. So we have just celebrated our 12-month in situ celebration essentially of our K2 end-to-end maternity digital system. That's been huge in data collection, in capturing areas for improvement, really being able to provide evidence of what good looks like and making sure our staff are supported to provide excellent care. So really big, 3 big wins for us before we start anywhere, because I think that they were things that were highlighted by the CQC, but we didn't need them highlighting. We knew they were issues and we went so far as to do what we could within our grasp, but we needed that support and that backing to be able to move forward. So on to the main task. I wanted to present to you today the plan that has been developed in relation to a multitude of work. We talked, and Bill mentioned a moment ago, about NOF4 and what that means. Obviously, our Devon ICB entered NOF4, meaning that all the maternity departments in the Devon region automatically sat within this. Now, part of this offer was for the maternity safety support programme to come in and do a diagnostic review of all the trusts within the region. And Plymouth was the first one to be reviewed. We were the soonest to have our CQC response, so it felt quite adequate that we went first. So they came in and performed a gap and a workforce analysis to look at exactly what we were providing, where our gaps were and where we needed to improve our service. So this was, looking at the real life experience of our service users, looking at our feedback, speaking to our staff, really trying to understand how things felt on the floor. In response to that, they provided us with a really detailed report. If you're happy just to move on one slide, that'd be fantastic. So essentially what we did as part of that is we looked at the CQC's must-dos, should-dos. We looked at our local and national guidance, what that recommendation look like, because we need to remember that the multitude of reports that come out don't necessarily meet our demographics and what's suitable for us in the southwest. So we needed to pull out of that what we felt was applicable to us. We looked at our gap analysis to be able to make sure we met the asks of that. Quality improvement is fab. We've all felt that we absolutely do that every day. It's ingrained in what we do, but were we following a systematic process, not just to improve the work we were doing, but to ensure that sustainability and that ongoing succession planning. Identifying local priorities, again, because there are things that don't come out in national guidance which are really quite key to us at UHP. And then recommendations from our workforce review. And we make no secret of the fact that workforce has been one of our biggest challenges. I think to the attract and the appeal to join the NHS now has changed, hasn't it? I think with litigation, I think with the pressures, with the negative press, and especially within maternity and neonatal services, is it that area of work that people necessarily want to, start to work within? arguable not so much anymore. So I think we needed to really focus on this, and central to that was our staff and our patient voice. So moving on, essentially what we did is a senior management team sat and we looked at all of these priorities. We pulled our risk register, we looked at thematic analysis from our incidents, how we were learning from practice, because actually that is how we inform, listening to our service users, really working with our MNVP, which is our Maternity and Neonatal Voices Partnership, who are lay people, they're our service users who come and they give us feedback. They come and provide 15 steps assessments. They live a day in the life of a patient and give us that real life feedback, which is hugely valuable. We pulled everything together that we've just talked about and sat in a room for day upon day looking at about how we bring together all of that thematic analysis to identify key priorities. Now, key priorities, there were 48, I believe, in total. And within those 48, we managed to develop 5 work streams. Those work streams were working equitably with women and families, developing a positive learning safety culture, infrastructure, which covered our digital and estates, growing, retaining and supporting our workforce, and then finally developing, embedding and sustaining a positive culture. And the 5th element in around workplace culture is absolutely key. We can talk about numbers, figures, stats all day. Unless we've got the right people in the right place that feel absolutely empowered to be there, that have the right support, the right mechanisms in place for debrief, for training, for education, then we're not going to get anywhere. We have to make sure that our foundations are absolutely solid to move forward. So, would you be so kind as to skip back a couple of slides if that's okay, whoever has to control? That's one more. Fantastic, thank you. So the first of our key priorities, as you can see there, and I'm really mindful that everybody's had this, and happy to take comments and questions at the end if anybody's got any challenge. But essentially our first key priority, and when we talk about access to services and inclusivity and equality of care, these were our main priorities that we identified within that work stream. We knew that we weren't hitting our Saving Babies' Lives recommendations within maternity and neonatal services. We've got 2 main reports or frameworks we have to meet. One of them is Saving Babies' Lives, which does exactly what it says on the tin. And actually the monitoring within that, we weren't quite compliant with every single aspect. So we knew we needed some immediate and essential actions in relation to that. I'm pleased to inform you, and I'll go on to tell you about it in a moment, but actually we've managed to do that, and we've just hit our Saving Babies' Lives for the first time in the last 3 years, coming in at 75%, so almost at our stretch target for UHP, which is massive for us. So going on from our sonography and fetal medicine services, it was our community services. How are we reaching those at-risk groups? How are we making sure we're taking care to our service users rather than expecting them to come to us? Identifying our areas of vulnerability and making sure that those families are supported well. Exploration of MLU, I think we've all talked about midwifery-led services and our inability to provide that, but what do we do within the remits that we do have? How do we make sure that the services we do have cater for high and low risk birthing families? How do we make sure that we support those people to provide offer of assurance, to be able to provide differing services dependent on what people choose to, how they choose to birth essentially? Our bereavement services, we need to make sure that's available 7 days a week. It's available 5 days a week at the moment. It shouldn't make a difference if you lose a baby on a Friday as to if you lose a baby on a Sunday. We absolutely need to make sure we've got parity of care across the board. Equally, we've included within that service user feedback and that MMVP work plan, listening to the people that use our service, allowing them to inform our services going forward. The second work stream looks more at around our governance structures and processes. There was a national shift recently of how we provide a proportionate response to investigations. We don't seem to find real deviations in the themes that come through maternity. We're dealing with the same things that Kirkup talked about 10 or 15 years ago. Although there's advances in technology and medicine, we still find we've got humans at the end of this. As much as we'd aim to do the best by every person that walks through our door, we don't always get it right. So what can we do to support people and make sure we're investigating the right things at the right standard and making sure that things are referred appropriately? So we have a new framework that's been adopted by the NHS called PSERF, and I'm happy to provide further content on that should you need it. To look at our risk register thoroughly to make sure that we have identified the correct risks and they're seen regularly and updated. Saving Babies' Lives we've touched upon already, and then also how we measure quality, our clinical quality dashboard, how we escalate that, how we can provide mitigation, and how we can provide assurance to our trust and to our service users. And then more than anything, quality improvement. Bill talked a moment ago about safety and quality. I think they kind of go hand in hand. I think if we've got one, we've got the other. And I hope that actually by providing some of the content today, you'll see what I mean by that. So going on very quickly, our digital and infrastructure and estates. Some of our services, again, a knock-on of COVID and the pandemic and what that's looked like. We saw a withdrawal of some of our community bases, which has meant that actually we started, I think, 5 years ago. We had about 50 places within Plymouth that we could provide antenatal care. We're now at about 17 or 18. That's been huge for us. We're no longer working out doctor's surgeries, which was obviously really, really great for us to be able to go in for people to access their services. That is no longer. So what we do need is to continue to reach out to be able to find venues that were suitable, that are affordable, and that actually are compliant with exactly what we need to be able to provide this care. So there's an awful lot of work going on in relation to that. There's also a lot of work going on in relation to what we have in the hospital. We'd all love a magic Christmas list of a bigger NICU department. That'd be fantastic. We'd love another theatre. We've got on there maternity theatre too, because it's really quite tiny. And as you can imagine, if one emergency happens, you can bet your bottom dollar we need the second theatre as well. And that second theatre is twins. And we've got a very tiny theatre with room for one resuscitator if you're lucky. So it's about this wish list, but keeping things safe. So although we're monitoring through this plan, those things we would like to have, we have to be very realistic with what's within our grasp. But I think that the continuation and the continued escalation to board of the priorities that sit within maternity services are huge, so it remains there. Our workforce, like I said to you, is incremental to all of what we're doing. We really need to look at how we're delivering maternity care. That changes. I think that communications with our service users has changed. We've got a time where digital literacy is fantastic and we can use that to our advantage. However, we do need to be mindful of digital poverty. We need to think about inclusivity. We need to think about our hard to reach populations. Are they hard to reach, or are we just failing to reach them? What are we doing about that? What are we doing about those language barriers? And it's not just language barriers, it's people with learning difficulties, it's people that have huge deprivation that just simply can't afford to access us. So what are we doing to reach out to these people? So essentially, I think that by making sure that we've got the right people in the right place, we've got the right backfill of staff in the community, our core community team that are going to be able to support us to deliver continuity of care, so that we've got that building of trusting relationships is huge. So the maternity redesign in collaboration with our staff is huge, and we anticipate that's going to be completed by April 2025. Again, all very much in line with our staff. It's all being co-designed with them. That also encompasses looking at our obstetric colleagues to make sure that we have the right number of staff to be able to provide safe services. That goes across our neonatal colleagues, and then equally the training and what that looks like. We need to make sure we have so many things that we have to be compliant with. There are so many elements of maternity care that's constantly evolving. So it's making sure that we've got that fine balance of our staff being present to be able to support acuity, because as we know, maternity happens when it happens. We don't have a list that we can work to. We can never gauge who comes through that door. We could be fully staffed every day and never have enough. We have on-call arrangements. That can still never be enough, whereas the next day you could have nobody on your labour ward. So it's meeting that demand, making sure that actually we've got the right people that are educated to provide those services. And then finally about staff retention, and our staff retention very much links into our last slide on our key priorities, which is about our culture. And it's about how we measure culture reasonably. We have lots of tools which are provided by the NHS in general. Are they fit for purpose? Because actually, if you just had a really, really busy day on labour ward or in the emergency department, you're highly emotive. The feedback that you're going to give is going to be very negative. It's going to be informed by your experience on that day, as it would be if you were on that labour ward like I just talked to you about, where actually there's nobody in, or you're in that random day back in whenever, when the ED department was really, really quiet. It's very, very emotive as to what you're doing. So it's about making sure that we're measuring it and measuring it accurately. I don't know that the tools that we have are applicable. So actually we're working to look at how we effectively measure that, how we can make sure that that's really palpable, and how we continue to make sure that we inform our practice based on people's feedback. Staff retention and staff well-being and staff satisfaction then are key priorities, looking after our staff, keeping them in the building, making sure that we're looking after their well-being, making sure that we're debriefing them, and making sure that they're absolutely happy to be in our workplace. So they are our key priorities. I want to talk to you very quickly as to who we've got leading these work streams. So of the 5 work streams, we've developed a plan. It's our maternity and neonatal improvement programme. So we've got 5 workstream leads. Our first workstream lead is Charlotte Wilton. She's our head of midwifery services. She seems absolutely best placed to be able to provide this and support this workstream with her background knowledge of community services. The next workstream is around developing a positive learning safety culture, and this is Sam Rafferty. She's our Associate Chief Nursing Officer, and she looks after predominantly our clinical risk and governance within the care group. Going on to the third work stream, we've got Steph Glanville, who's one of our cluster manager. She absolutely deals with our procurement and our staffing, our job planning. So again, feels very well embedded in, and knowledgeable. Going on again, we have got Helen Harling, who is looking after retaining our workforce. This is really, really key. She was a midwife by background, then she went to a matron in maternity services, and now she's just been promoted and she is our head of nursing for the Women and Children's Care Group. So she's got a really good grounding within both sides to look after maternity and neonatal aspect. And then finally, we've got our transformation midwife. Sarah Saxby is a midwife who works predominantly with looking at improving services. She looks at our communications, she looks at dealing with our maternity and neonatal voices partnership, and then also outsourcing, really feeling what's going on the ground and providing that feedback to us. So we feel that we've got really strong leads that can support and make sure that we've got some tangible actions and movement across this plan. Now the plan itself has got 144 actions, okay? So if we go on very quickly, I want to just show you a snapshot of this. Now, I'm not sure how well you can see that there, but I'm hoping you've all got your presentations in front of you or online. But just to give you an idea of the granularity of this, so this is one of our very first comments, and this is what I talked to you about a moment ago, in relation to our uterine artery Dopplers, which was one of the things we were failing to achieve to comply with Saving Babies' Lives standards. So within that first element, and with every element, we have got a goal, a method and an outcome with a KPI. So what are we going to achieve by completing this? And if I can just talk you through what one of them looks like. So if you look at the first page, you can see that actually we've looked at how we're going to train and adequately make sure that our staff are embedded. We've got enough staff to provide the service. We're going to succession plan to make sure that we continue to have enough staff. What does that look like? We realised that we had an ageing population of sonographers. So what are we going to do to mitigate that, not just for now, but what we're going to make sure to do, going forward, so we have that continued succession. Equally, how we're going to train our staff to be able to perform this additional skill. And then finally, to be able to implement. So if we go on to the next slide very quickly, what you will see is we've got a workstream lead, a goal lead, a time frame, an expected time frame of completion, and then RAG rate. So actually this report gets reported and escalated to board and our maternity and neonatal safety champions on a monthly basis, so they can see how we're being RAG rated, if we're not meeting our deadlines, if there are any risks or barriers to us completing. That's absolutely escalated through our RAG rating. We have a repository of evidence, so anybody should, touch wood, the CQC have come yesterday, we'd absolutely be able to point them and give them assurance of where we keep everything. So everything is centralised now. And as you can see as you go along, we've got a bit of is only a tick box exercise, but it gives us assurance by meeting that first ask. What are we achieving? So for example, with the first one, we know that by achieving and providing uterine artery Dopplers, we're going to be able to be compliant with Saving Babies' Lives. It's going to be removed from our risk register because we identify it locally as a risk. Equally, we should be able to hit our CNST. So it's that quick benchmark, and it's about how we can visibly see the impacts and the ongoing interdependencies by hitting this, what else we can achieve. So it's a really excellent way for us to be able to demonstrate that compliance. And like I said to you a moment ago, we're really, really proud to say that one of those things, which has been huge for us, we've successfully completed. So as of the 25th of October this year, we are now providing uterine artery Dopplers for every mother that's deemed to be high risk of having a fetally growth restricted baby. So going forward, that's huge, and that has supported our submission for SBL and our compliance with that, with meeting SBL and CNST. Also want to demonstrate at this point that this tool, with us leading the way at UHP, has now been adopted across region. So this document, this plan, our ongoing reporting, obviously with permissions from the Trust, they've happily now rolled this out. So every trust within the Devon ICB is going to be using this template for reporting, which provides some assurance, some standardisation in how we go on to report. We're going to have a really succinct way of being able to lead this going forward. So really quickly, the reporting and oversight, I just to give you some assurance really of how that's going to look, we've got a high level plan that's going to be reported every month to our board, and then that's going to go out to region and the ICB. So that slide that just came up a moment ago is just, it looks very complex and complicated. I promise you it's not. If I can do it, anybody can do it. So that's a starter for 10. But this just is a very high level report that's going to, for every single one of our work streams, to give that ongoing trajectory, to mark things that are at risk, any barriers or anything that needs immediate escalation. Because the exciting thing about this plan is this is putting maternity on the map. I think for a long time there's been so much in the press, so much in relation to national drive and narrative around what we should be doing, what's best practice. But I think the healthcare organisations haven't necessarily recognised this. For the first time, we really feel that we're up there with the Trust One plan, which is absolutely huge. So a lot of these slides are absolutely identical to what has been reported in the Trust One plan. So we are up there in the broad daylight of our Trust Board of Execs.
Shall I just explain that? What Natalie means, I think, there is this goal method outcome. We take this approach across every single project in the Trust, and we have one plan at the moment, you might have heard of it, one plan to improve urgent emergency care, which is probably our top priority in terms of improvement because of our long ambulance waits. So we have a goal method outcome approach to everything we do, and this is as much in maternity as it is in our urgent and emergency care services. So this is an approach we take across the Trust, across all services. So if you hear us talking about goal method outcome, it's because that's a standardised approach.
Thank you. If you would be so kind as to go on again, that'd be fab. And just to give you some assurance of how we escalate this, so this is not just in-house. I hope that this gives you an indication as to how that looks in-house. We have those 144 recommendations, actions, which are absolutely seen and presented by the workstream leads on a monthly meeting. So on a monthly basis, the 5 workstream leads would meet with myself and our Director of Maternity Services and our compliance lead. We would sit, listen to their updates, request evidence where needed, and hopefully, surely and slowly be able to provide assurance of all of those actions to be able to move towards completion. Nothing goes completely to completion until we've got absolute evidence and audit to assure that we've got business as usual. So I think that we've got a really robust way of making sure that these changes are palpable and sustainable. We then report into our Trust Safety Champions to make sure we've got that oversight. Then that goes up to board. Once our board are happy, we then report to region and ICB on a monthly basis. So they have that oversight and that overarching ownership of the plan. Our aim is to be able to fulfil this plan and to meet the exit criteria as soon as we possibly can. When we relate to some of the other trusts that have gone through the same format and the same process, some of the trusts nationwide have taken a long time to be able to exit that plan. We feel confident with the amount of actions that are on our plan that shouldn't come with a longevity. we feel really good trajectory towards all of our actions with some really good mitigation in place. So the one thing I must say about this, even though we do look to work towards an exit criteria, which is absolutely fantastic, I think this is a process we're going to adopt going forward. This is a centralisation of all of our priorities. This is one place for us to go knocking with a big knock, rather than everybody trying to get the trust's attention with, you know, tapping on that desk with a sponge. I think this gives us that absolute backing and that absolute certainty that we're going to be heard. So this is exciting for us. We're really, really keen to see how our services improve. And I think already in the very short period that we've started reporting in this way, we're already starting to see some real tangible change. So thank you. I think that's me. Does anybody have any questions?
Thank you, Natalie. It was an excellent report. I just have one question. It's too early to assess it just yet, but I was just wondering what effect your work has on the future health of the mother and baby, and whether you have a reduction in paediatric services as a result, and other services at Derriford.
I'd absolutely like to think that was the case. I think that all of the evidence and research completely supports that our intervention and our early years involvement is absolutely incremental in the long-term health, mortality and morbidity of our infants and children. So I think that early intervention and compliance with this plan, and I think it was shared with you, and if you look at the detail within the plan, we look at how we're going to really support infant feeding, how we're going to make sure that we have enhanced antenatal care for our families that are vulnerable, how we're going to make sure that we've got that enhanced feeding support for these families, that every mother's going to have a first visit at home within 36 hours of discharge, which we're not currently compliant with. All of those interventions, we really hope then will give people timely care and will reduce that morbidity and mortality. I think the antenatal education, accessing services and really understanding our areas of deprivation will be huge also in making sure that we're supporting those families, that continuity in the community. We hope that we'll embed a sense of trust, which will allow us to really uptake our face-to-face bookings with the acquisition of more centres to be able to provide that antenatal care, that initial risk assessment, making sure that people are adequately seen, that they're put on the right care pathway, would absolutely impact the long-term, outcomes for these children.
Kate.
Yeah, not a question, Chair, just a comment. I'll be watching this with interest. I've got an interest in maternity services. I'm from Shrewsbury, of course, the Ockenden Review. I just wanted to say how refreshing you are. Like, a lot of people come to Scrutiny, and it can get quite, I wouldn't like to say dull, Chair, but it's just nice to see someone with so much enthusiasm for what they're doing. I think, and hopefully Amanda can pass that back to the powers that be at Derriford, because I think it's really nice to see someone so passionate about their work. So I just wanted to let you know that.
Thank you so much. That means the world, because actually I am. That's absolutely me. That's what I want to do. I've had children at the Trust, my friends, my family, people that I care about, the city that I live in. I want absolutely nothing but the best for everybody that accesses our services, because in some shape or form it will affect all of us. So thank you. It's really kind.
Ray.
I've done it. I'm working up there again on Monday night. Currently, a number of us can't get access to maternity to bring mums and babies up because of an incident that happens somewhere else. Is that likely to change any time, or do we have to continue to pull nurses away from stations and what they're doing to open doors for us to get beds through?
Can I ask what capacity you work in?
Yes, so I work for Louise Pelly, and I work for hotel services. I'm a porter.
Amazing. I can't imagine that things will change. I think that there's been a huge movement in relation to the security of our infants, our babies, and our vulnerable families. Whilst we strive to make sure that the right people have got the right access, I know that there has been issues, and I think that has been addressed if not already. But I will take that back, and I will absolutely link in with you to make sure that you
I
do.
haven't had any shifts for a while. So.
Have you not? It's a shame, but there does seem to be an issue, and I think that it's been highlighted internally. I think within maternity particularly, we've got real heightened security, and I can't imagine that's going to change. And I think if you haven't been there for a little bit of time, and it's a really short period of time, they block access, understandably so, but completely feel your frustrations.
Thank you both, and thank you for your enthusiasm. I've got one brief question about retaining staff. I'm a trust employee, so I was able to retire and return. Are midwives now able to do that?
They absolutely are, yeah.
Is that a recent thing?
It is.
Fabulous, because because obviously, you know, you've got an experienced workforce there.
Yeah, absolutely. And I think it was something that was, again, a bit of a frustration for many, because we lost some really experienced staff, and we couldn't afford to do that. We've got a very junior workforce now. We absolutely rely and couldn't get by without the experience of the people around us. So I think that we were absolutely missing a trick there. That has changed, and we've got quite a few members of staff now that are on retire and return. So it's lovely for us.
Any more questions?
Love to.
Anybody else got a question? Thank you very much. Right, next item is item 10. This is an item for note only, and there's no policy officer here in attendance. The report sets out the recent government announcements and priorities to inform the work programming of the panel. So we just have to note that report. Okay. And item 11 is tracking decisions.
Thank you, Chair. So members will see 5 tracking decisions on the log. I'll run through each of them briefly. Tracking decision 1 related to clarification on winter preparedness from our last meeting has been completed, and a response from Alex Deegan is within your packs. Tracking decision 2 is marked complete, which was the addition of urgent emergency care 1 plan to the work programme. Provisionally scheduled that for the next meeting, but it can be moved, and we'll come on to that in the next section. Tracking decision 3 was a request for performance figures for sickness, staff sickness and adult mental health. Obviously that's provided today in today's report through the Live Well performance and the PCC performance report. Obviously noting that we will be adding that to the work programme to bring that back, and there are a few actions associated with that one. Tracking decision 4 was the end of life care recommendations. Now we obviously had a update from NHS Devon at the last meeting, and while probably around half can be agreed as complete, there are some on there such as falls prevention that we might want to bring back to future. So with permission of the panel, I'll pick up with Chair and Gary, and we'll work out which of those we might need to probe further, unless anyone has any thoughts. And finally, the last one, which has been on there a while, relates to defibrillators. This is ongoing, and we have submitted a bid for funding. The bid remains outstanding, so as soon as we get a decision, we'll let you know. That's all. Thank you, Chair.
Thank you. Right, agenda item 12 is the work programme. So what have we got here?
So through you, Chair, I've very provisionally scheduled the Armed Forces Friendly GPs and Dental Surgery and the progress or performance review of the Urgent and Emergency Care 1 plan, which was essentially following on from our session on winter preparedness. How have the capacity measures performed through the winter? Have they held up? Welcome to amend and change those if members have got any ideas. If not, we'll revert to usual processes for agendas.
Can I request, like, can I tell you which one I'd really like to see at the next meeting?
Yeah.
The health and wellbeing hubs. I want to see how they're getting on. I opened a load of them. I want to see how many are left.
Yes, no problem. We can pick that up at the agenda set, Chair.
It was also suggested during the course of the meeting that we should have on the work programme the sickness of care workers.
Yeah, thank you, Chair. As we'll pick up in one of the actions from today, there's that part about bringing the Live Well performance report back. So I'll pick up with Gary, and the most appropriate time, maybe at the next meeting, the one afterwards, we'll bring that back. And at least in between, there are a few figures we requested. So if it's not a full report, we'll get the figures before the full report.
I think it's better if we're having meaty stuff to space it out, like the one thingy, the Derriford thing. That'll be quite meaty, and I think the Live Well thing would be quite meaty. So I think it might be worth separating the two so as you don't get brain fry.
Thank you very much, everybody, and wish you all a very happy Christmas.
Yeah.